Thank you guys for being here. I've been looking forward to this meeting for a couple of weeks now. We've got some really good speakers, some really good information. I encourage the members dig in and ask a lot of questions. This is obviously a massively complex subject that we've found ourselves diving into here. Today, both this morning and this afternoon, we will have people who are truly national experts on this subject. So hope that we will all take advantage of that. Ask the questions that you've been dying to ask, because if you ask me, I'm just going to kind of shrug and look confused. But if you ask them, they're actually going to give you good answers. We are, I think, working on the handouts. If you don't have the handouts, well, I was going to say Chelsea from my office is here, but she may still be printing things. But we do have printed handouts for all three of the speakers, so they will be making their way to you as the morning goes on. With that, without any further ado, we are going to kick it off. I've asked Deputy Secretary of Health Kimball to start us off today. Just kind of one more effort to define who it is that we currently take care of through our Medicaid programs, and kind of define that population. It became clear in the last meeting that there was still some confusion on who we cover, and maybe there's more confusion on who we don't cover. So I've asked him to start. Even though he's actually a member of the committee, he also gets to be a dual threat and be a presenter. So with that, Deputy Secretary Kimball, I know you don't have much else going on in your world, so
not at all.
Very much appreciate you creating this presentation and being willing to be here and do this. And members, I will tell you now that he has a hard stop at 9:55. He has a 10 o'clock meeting down on the floors of this building that he normally works on, that he has to be at and shall not be late. So let's use that time wisely. And with that, thank you very much for being here.
I appreciate the introduction, even though the promise of national expertise and world-renowned knowledge will start with the next presentation. For this one, you get me. So very quickly, just kind of housekeeping on background, and then how I'd like to see this presentation kind of go. So I first cut my teeth in the state working at the Oklahoma Healthcare Authority. I did public affairs, external relations, and government relations for 6 years there. I then served a short stint at the State Health Department for about 18 months before I moved on to Oklahoma State University, assisting their Board of Regents with their medical school and the state hospital up there. All of that is really just kind of context for, I would like for this conversation and my time to be very short on presentation and as long as you want on Q&A, and to have as open a conversation that we can, with the understanding that if I can't answer the question sitting here today, you have a commitment from me to go and find it, and so we can have good information as you guys go forward and start working on developing some recommendations. So with that, kind of the general premise, and one that kind of pull this one out. This is really just a cheat sheet because almost every slide I have says FPL somewhere. FPL is federal poverty level. This is a breakdown with household family size on the left, with the percentage of the poverty level running across the top. The important note here is that as you see that household and family size, especially for things like advanced premium tax credits on the marketplace or Medicaid eligibility and things like that, that household is tax household. So we're lesser concerned with the relationship of the people in the household. If grandma and grandpa are taking care of kid and kid is under their tax household, that's the number you're looking for on the left. So at which point, as we start kind of roaming through who's covered and who's not, this is the cheat sheet. Pull that out. That's all the time I'm going to give to it. So very quickly, this is, even though it says the Ma Snap Show, this is the Oklahoma Snapshot. As the Ma Snap Show is just my shortening. I'm very efficient. We try to be as efficient as we can. So why use 14 letters when you can use 8? So very quickly, the chart on the left. Insurance category in relatively broad terms. I used 2017 annual numbers. They're kind of certified and reliable, but it is a good kind of snapshot for comparisons across. The first caveat, and I know that I'll catch it, the Medicaid number here is a self-reported number at a point in time. So you're going to look at it and go, oh, I thought we had more than 684,000 on Medicaid. Even in 2017, we did, but at any one point in time, that number fluctuates pretty greatly, and that's people coming on and off. It could be anything from pregnancy to aging out to new income and things like that. So point in time and self-reported. So as you can see, by insurance category, employer is what vast majority of the state and vast majority of the country is affiliated with. That is, I am in a group plan through my employer. Included in that, the first bullet, state employees and all those that are covered through the employees group insurance division, they're included in that top number as well. I don't know what the number is for 2017, but most recently it was about 125, 150,000, somewhere in there. In the non-group category, this is your individual market. So this is somebody going and straight to purchasing a plan. As you can see in the second bullet point on the right, a vast majority of those are getting insurance through the federal marketplace. A little bit later, we get into, or just down the slide, it breaks down of the people who are on the marketplace, who are getting those plans, 95% of them received a tax credit used to subsidize their premium. So the note there being 100% to 400%, right? Cheat sheet. Those, if you are in between 100 and 400% of federal poverty, you are eligible to receive a premium tax credit, which is not given to the individual, but instead given to the insurer to subsidize, to lower the premium that you are required to pay on the marketplace. That is on a sliding scale. So the premium subsidy that you receive at 101% of federal poverty level is all of it. It is a free, there are plans that are available that are free at that low of income. At 400%, the subsidy almost disappears. So at which point there's a big scale in there, and so that's what that 95% number recognizes. The 64% number receiving a cost-sharing reduction, once you have the plan, you still have cost-sharing requirements, co-pays, deductibles, out-of-pocket costs. If you are in between 100% of poverty and 250% of poverty, you are also eligible to receive reductions for those co-pays. So that's what that cost-sharing reduction is. As you can see, 64% of the roughly 150,000 that got insurance through the marketplace in Oklahoma received cost-sharing reductions. So the math you can also do on that is about 1/3 of the marketplace did not receive cost-sharing reductions, but more important to this conversation is that tells you that you've got a 2/3, 1/3 split from 100 to 250 and 250 to 400. So There are a whole lot more folks on the marketplace in that lower income band that are getting that subsidy. Kind of referring back over to the chart on the left, Medicaid and Medicare, we'll get into Medicaid a little bit more. Medicare is for elderly and disabled. The important definition there is that if folks that we know as duals, those who are eligible for both Medicaid and Medicare, for this purpose, for this chart, they are counted only in Medicaid. The point there being that Medicaid takes up all of their cost sharing and things like that, and for the most part, that would imply that they are also eligible for either home and community-based services or a nursing home. So there's still tremendous expense on the Medicaid side, even though Medicare and their Part A and B and drug benefit is still there. Other public, and it notes this out to the side, is military and VA. Other public is not state employees or anything like that. So that's just Veterans Affairs, military through TRICARE and things like that. And then the uninsured number, 532,000 roughly. Tribal members who receive services only through IHS, so they don't have any other type of insurance, would be in this figure. I'll stop here. Questions?
Representative Lawson.
Thank you, Mr. Chairman. Of those tribal members only insured through IHS, do we have an idea of what that number is?
I looked for this number, and because I was giving you 2017 numbers, I couldn't find it, but I can go back and tell. So the tricky thing is that the reason that they don't count it as insurance is because it's really not insurance. It is free clinics, effectively. The premise of insurance, grouping the risk, doing some actuarial benefits and things like that, doesn't exist within that IHS structure. And so for the conversation of insurance that really is separated out, the best that we can do, and this is one of those homework items that I can take back, is like member visits to IHS clinics. They're not tracking, here's a member that's enrolled. They're tracking the number of times somebody comes in to seek services. So it's not exactly apples to apples.
Representative Rowe.
Thank you, Mr. Chair. So just to clarify on the IHS, these individuals go to the clinics sponsored by the Indian Health Services. Who covers the cost of hospitalization if these individuals require hospitalization or a surgery or something of that nature?
So there is a process in place where the facility can try and recoup through IHS. IHS is the non-discretionary side of healthcare at the federal level. And so they're appropriated, and they, at least when I was paying better attention to that, they ran out of money for that kind of service in about April annually. And so for the most part, that's another nod to why that group is not counted as insured, because outside of some primary care, and some of the tribes have facilities that do specialty and hospital and things like that. But for the most part, once you're outside of that system, you truly are uninsured. You don't have a payer source.
Follow up.
Thank you, Mr. Chair. So that means then if that individual, say, has open heart surgery, and there's a chance that that hospitalization and such is not covered, so they're either going to be qualified under indigent care through the facility or the patient's responsible for that amount of money?
That's correct.
Thank you.
Yep.
Senator Hast.
Thank you, Mr. Chairman. Related to that, so basically under the uninsured, we're showing roughly 14% of Oklahomans uninsured, correct?
That's correct.
Okay. So even though it's not true insurance, they are receiving some health care, correct?
That's correct.
Okay. So I guess part of, as I look at this, with not breaking it out or somehow addressing that, it's kind of giving a false number, which plays into rankings and that type of stuff, and which is showing more in a negative fashion than in what reality actually is.
I think that there is an important component of the fact that we have such a large tribal population in the state. And so it does kind of build into this, but the consistency across all states is being measured the same. So just as in other states, they would be dealing with some of the same dynamics of, is this person truly without access to care, or are they simply uninsured? I mean, one of the points that I would make is that, you know, the non-tribal uninsured, here's the other piece, there are a lot of tribal members in the state of Oklahoma that are insured. So that's a really important kind of caveat that I would put out there, that it's not to say that every tribal member in the state is in this uninsured number, because many of them have insurance through their employers, some of which might be the tribes. So at which point, that's an important caveat. The other is that any rank and file uninsured individual can seek services through a federally qualified health center, or through indigent programs, through the hospitals, or things like that. And so it really is a sense of how comprehensive a benefit does somebody have access to, not because they're uninsured, they just can't seek health care anywhere.
Representative Ranson.
Thank you, Mr. Chair. Question on the VA military number.
Yeah.
Are these, this population excluded from the Medicaid, Medicare numbers?
Yes.
Okay, just wanted to make sure, sorry, follow up, in the sense that this, the Medicaid numbers do not include the aging military.
That's correct.
Thank you.
Yep.
Representative Stark.
Thank you, Mr. Chair. I have a question back with the tribal. When they apply to avoid a tax penalty, there's a form that they submit to the government, to the marketplace, to say, or to say, I am covered for their taxes. Is there a way to get that number that is saying, I have tribal insurance, I don't have to get the other insurance, and I'm covered?
So the tax penalty was zeroed out with the tax reform at the federal level this last year. And so there isn't a penalty any longer for an individual mandate. That's what they were trying to comply with. So the penalty is zero.
Follow up.
But for 2017, could we find out how many of those filed that form to know that they were
I get your question,
taken
yes.
out of the uninsured?
Yep.
Thank you.
That's all the questions in the queue
Okay.
for now. If you'd like to continue.
Yep. So diving a little bit into kind of the snapshot of the state. As we kind of saw with the cost sharing reduction, but now I'm going broader than what's on the marketplace or anything like that. 68% of all Oklahomans are under 400% of federal poverty. So 2/3 of the state, in theory, 2/3 of the state, as the Affordable Care Act was originally intended, because remember, Medicaid expansion was part of the Affordable Care Act until the Supreme Court made it optional for states. So the premise and the landscape of that federal law was that everybody under 400% of federal poverty would either be able to access Medicaid or the marketplace through a subsidy. That was the design, as flawed as it may have been, that was their thinking. When the Supreme Court came back and made Medicaid expansion optional, an error in drafting was quickly identified, that there was an overlap in the Medicaid expansion and the federal marketplace. So Medicaid expansion was up to 138% of federal poverty. In a different section of the quadrillion-page bill, the marketplace subsidies were from 100% to 400%. So states immediately identified this catchment as an overlap, and the federal government has since said, if your state expands Medicaid, then those people up to 138% of federal poverty are no longer qualified for tax credits on the marketplace. You are qualified for Medicaid, you are not qualified for tax credits. Some states worked around that by purchasing marketplace plans with Medicaid dollars. So that's the Arkansas model. Indiana has done some of it. There are other states that have premium subsidy programs that look eerily similar to our Insure Oklahoma program, in that we use Medicaid dollars to go purchase a commercial group plan. That's what Insure Oklahoma looks like right now. That Insure Oklahoma program is only for those employed by a small business or self-employed, and it's only up to 200% of federal poverty. In 2018, 36% of subsidy-eligible populations, so these are the people that could go to the marketplace, receive a subsidy for their insurance plan, only 36% of those potentially eligible enrolled in a marketplace plan. That tells us two things. One is the uptake on the marketplace was not very good at all, which does a lot of different things, keeps premiums relatively high on the marketplace. Obviously, the more people you have in, the lower the premium. It also lends itself to somewhat of a, it starts looking more like a high-risk model, to where the people who are going into the marketplace are the ones who actually need the insurance. And the ones who are not, about 2/3, who are eligible for a subsidy but not exploring it, have done the math and said, yeah, it's still not worth it for me. Subsidy's not enough, premium's too much, I'm healthy, whatever it is. So that's an informative piece for us to keep in mind. And then the last point really is kind of back to how people get to insurance. And that's about half of Oklahoma's private sector employers. So whether you're for-profit or nonprofit, if you are an incorporated private entity, about half of them in Oklahoma offer insurance to their employees. About 32% of private sector employers with fewer than 50 offer insurance. Of note, that's actually above average. I think this is where we get to kind of pat ourselves on the back with the acknowledgement that we can do better, but I have to believe that Insure Oklahoma is filling this 4% delta there. That really is the rest of the country has struggled with getting employers to a point of providing it. We've kind of figured something out and we're able to do that, and that's been in place for almost a little more than a decade now. So, just to throw another comparison for context, this is back to Senator Hayes' point about percentage of uninsured. There's a lot of conversation when states and others have kind of talked about what does something like expansion look like and how does it impact the market writ large and different things. This is really the acknowledgement. You can't really see it. The yellow slice is Medicare. That's 15% in Oklahoma and 14% if you can't see it on your printout. But the uninsured, the green slice, so the national average is 9%. In Oklahoma, it's 14%. Senator Hayes pointed that out earlier. But the pickup, the largest difference between our state and other states is actually the employer market. It's not Medicaid. As a percentage, the difference between our employer market and other states' employer market, ours is lower. And so I think that this kind of gives us context for where our citizens are and things like that. There is need for pathways to insurance that is above and beyond the ability to expand Medicaid. This is kind of as you look at both non-group and group in the United States, that accounts for 56%. Whereas here it accounts for 51%. That delta actually brings us back in line with national average for uninsured. So that's kind of the point of that comparison and drawing that out. Again, my title box forgot to expand with my text. That's current Medicaid coverage. This is a snapshot. This little snapshot, the total enrollment, this is a monthly report that the Healthcare Authority does. It's under the Fast Facts tab on their homepage. It's a great resource for this, but it really is the breakdown of here's who's on the program. Again, this is point in time. This is July of this year. And so as you can see, I'll start from the top going up because of the specificity of the eligibility. To get onto Medicaid currently, you have to be a resident and you have to fit a category, and then within that category, you have to meet the financial strictures. So there are also full benefit and limited benefit plans. So one of the things that will drive to this, well, 3 slides ago you said it was 680-something thousand. What they are counting is full scope benefits. So the Oklahoma Cares, the breast and cervical cancer waiver, and then the Sooner Plan, the family planning waiver. That's an example of limited scope benefit. The other category, it's in the small print down here, but it's a couple of different, over the years, Medicaid has added some different populations, TB, refugee populations from certain countries and certain time frames and things like that. So there are some catchments that we get within that. Again, it's not extremely large, but it is a part of the puzzle. Working my way up, children and parents, that category is the children and then their adult caretakers. Remember the tax household conversation? Doesn't have to be biological parent, it's who's in your household. So they have to fit an income threshold. The child is eligible at a much higher income threshold than the parent or caretaker. So the parent caretaker right now is at about 45% of poverty. That's where they're eligible. Child is around 200%. There's some withholds and stuff like that once you get into the tax reporting and stuff that it wobbles a little bit around 200%. So that's an important category that the children and parents don't assume that because they're listed together that they are eligible at the same income level. They are not. That is to reflect simply that they are otherwise able-bodied, is the term that we've gotten kind of comfortable with. So those are the households. So that 72,767, those are over the age of 19, they are under the age of 65, and they are below 45% of the federal poverty level. So you can flash back and do some mental math, and that gets you to about household of 3. It's about $9,000 annually. Going up one more, this is the age blind and disabled. This is where you pick up a vast majority of adults. So aged is simply over 65. Blind, I think you can figure that one out. And then disabled, a disability determination is required. There are pretty extensive medical needs assessment and things like that that makes you eligible for that. But that's the adult, that's the largest portion of adults that we have on Medicaid currently. You have to fit one of those 3 things, aged, blind, or disabled, and the income on that varies. The disabled group is a little bit higher. The age group is at 100% of poverty, but still exceptionally higher than the non-disabled group. Questions?
Representative Rowe.
Thank you, Mr. Chair. I'm looking specifically at the Oklahoma Cares program.
Yeah.
And I actually will preface that with that I've had several patients that have qualified for that. I'm a little shocked that it's only 381, 361. I can't see it very well from here, but are there any statistics that show if there's any women in the state that have breast or cervical cancer that have remained uninsured for some reason?
I don't know, but I can definitely go back and look. And another important factor with the Oklahoma CARES waiver, if you are similar to the disability category, there are definite medical assessments and documentation and things like that. So if you're in remission, you're not eligible. You have to be in active treatment. There are some other requirements that I'm happy to share as well. That's well into the weeds of how somebody gets on through this program. But it is safe to assume that that 381 at that point in time are actively receiving treatment in the month of July.
Follow up?
So I'm actually a screener with the BCC program.
Yeah.
Although I've not had any patients recently qualify or seen me for the screening, but I thought at one period of time, like the women who were taking tamoxifen or one of the long-term medications for breast cancer, are they no longer covered for that part of the treatment?
I believe that they are, but that would be that limited scope that I mentioned previously, so it's not a full scope benefit at that point. But yes, I do think the pharmacy benefit is.
Senator Stanzlowski.
Thank you, Mr. Chair. So just a couple of quick clarification points. Aged, that's age 65. Child is 18 or under or less than 18.
I believe that it is 18 and 364 days,
Okay. So less than 19.
less than 19.
Less than 19, all right. And then finally, so with, if the state were to expand Medicaid, essentially then we're saying we're getting rid of the age between the less than 19 to age 65. That's no longer a factor. And now the only factor really is finances. How much do you earn? Is that correct?
That's right. You would be taking away the categorical eligibility under age 64. Under age 65, 64 and 364.
So I will ask what may be a dumb question is, other non-expansion states, or I guess states before they expanded, did they cover different population groups, or is this standardized nationwide? This is what Medicaid does in every state?
So this is very, very different. I'm sure that for those of you who have been in the building enough, you have heard if you've seen one Medicaid, you've seen one Medicaid. That is 100% true, and different states are able to, within certain parameters, establish different eligibility guidelines. As an example, the state of Wisconsin covers adults up to 100% of poverty without the enhanced match through Medicaid expansion. So right now, they pay a regular program match for that group so that they don't have to take on the 100 to 138%. Utah tried, got denied. Georgia is in the process of trying that partial expansion up to 100 to avoid the overlap with the marketplace. There are states currently that pay regular match for that group just so they don't pick up the 100 to 138. So it is very variable, and the last slide kind of gives that a snapshot of where those states are.
Representative Rowe.
Thank you, Mr. Chair. Looking at the financial eligibility, I need some clarification. And you said that's household income. So if you have, say, a couple of adults that may or may not be legally married, and there's 3 or 4 children in the household, are we looking at the entire, and let's say that the male partner in that household may or may not be the father of the children, do we still look at his income as far as the household income if he's employed, or how does that work?
It depends on how they're filing their taxes. And that, in addition to just administrative, I think that the ability for multiple families within a household, commingled kind of within the way that the decision was, or the way that the law was drawn up was really to default back to how you file your taxes. If you're filing together, then yes. If you're not, then no. And it actually depends on who's taking the tax credit for the children as well. So ultimately, the hangup could be that if dad's trying to claim the children as a deduction on his taxes, or male or whoever it is, but the kids show up on the female's taxes, that's where that flag will catch in the Medicaid system to say, hey, something's gone wrong, we've went and checked back and have run back against. And it's an important point, one that I skipped over, but the Healthcare Authority right now, that eligibility determination is automated. It can get flagged and run back down. For the age blind and disabled population, employees at DHS actually do some checks there. They go back and look at assets and things like that for people who may have a home in the community but are in the nursing home now, and so it's a little bit more manual. But the automated online enrollment rules engine goes back and hits Social Security Administration, OESC, IRS, Homeland Security. So those checks are automated and can flag if there are discrepancies on tax household or where these children actually exist or if they show up twice. And so there are abilities to kind of catch those, but if there's a clean break in filing the taxes, then it's pretty difficult for us to catch.
Representative Fugate, then we'll have Senator David, and then I'm going to stop the queue, so make sure we get to the last slide that he has and honor his time commitments.
Thank you, Mr. Chair, and thank you, Secretary,
You
for
bet.
being here this morning to speak to us. You mentioned the 100% that some states are providing, and you mentioned that in the context of regular match, and I assume that's regular match versus the expansion match. Can you just clarify a little bit about that process?
Yeah, so we heard a little bit in the first meeting about FMAP, Federal Medical Assistance Percentage, and that is a rolling 3-year number that the federal government calculates for all 50 states and the 6 territories in Washington, D.C. And so every state's match is different. There is program match. There is, which currently is about 60-40 for Oklahoma, 60 federal. There is administrative match, which is paying salaries, keeping the lights on at the building, all those kind of Medicaid crucial functions. That's 50-50 for all states. There is medical match. So if we have employed case managers, some of the medical directors that do some clinical things, just in chart review and stuff like that, that can be approved for 75-25 federal. And then there is what used to be the default enhanced match, which really had to do with technology, how to improve your claims management system and some of your database functions, your MMIS, your Medicaid Management Information System. It's a massive database and information system that the Healthcare Authority has. Some of those activities are eligible for 90-10. And then Medicaid expansion, just for that new adult population, is eligible for 90-10 as well.
Follow up.
Thank you, Mr. Chair. And so speak then about the qualifications side of that. We have categorization today based off of how we've implemented Medicaid. Do they have that same kind of categorization? Or do they effectively have the equivalent of Medicaid expansion?
So the categories that exist continue to exist for the non-expansion population. So the age blind and disabled, that sticks for those above 65. If you are below the age of 65 and you are a resident and you are under 138% of poverty, you are qualified. If you are newly qualified, you are eligible for 90-10 match. If you were qualified previous to that expansion, you remain on the 60-40 match.
Final follow-up.
Thank you. Maybe I didn't ask the question quite correctly. My question really was about those states that have that 100% that chose to not do Medicaid expansion.
So they are under their regular match. I don't know what I don't know what Wisconsin's match rate is, but they are under regular match for those adults up to 100%.
Categories, those still?
Yep, categories still exist. They just expanded that parent caretaker category.
Senator David.
Sorry. Thank you, Mr. Chairman. Okay, I have a couple of questions that hopefully I won't take you down a path here that's a rabbit hole, but I was just trying to get some clarification on that 100% to 138% population, because you made the comment that some of the states, like Arkansas and was it Indiana, that have kept that population, they've used Medicaid dollars to purchase insurance. Can you explain a little bit more, is that how that works? Is that with that population, is that an insurance program with capitated rates so that they can get that match back? And then if you would also kind of explain to us why that would benefit them instead of just putting them in full-blown Medicaid.
Sure. So to the first question, it can be either. Arkansas, as an example, simply took the Medicaid funds and purchased a plan off of the marketplace. That is just a Blue Cross Blue Shield or whoever's offering on the marketplace. They went and purchased that plan. Some other states that have capitated managed care, they have kind of blended some different things to be able to direct certain members, and I think you'll hear some of this in future presentations today, that have more of the national perspective than I do, but you can modify that benefit for that population. The federal government's kind of hard stop is that they have to be covered, and if you're going to do it through Medicaid expansion, the switch is just from dollars coming from IRS and the Treasury pays for that subsidy, to HHS. And once you're under Medicaid, HHS now can pay for the subsidy to get onto a private plan. The benefits of which ultimately the state has less exposure potentially to cost overruns and things like that if you're on a private plan, because you're simply going, whether you capitate or just purchase the premium, your exposure is limited because you're not paying fee for service. The other piece to that is that if you do it through Medicaid, there are laws in place for Medicaid that limit the cost sharing that you can apply to a person. So if a person on the marketplace right now, they get these cost sharing reductions, on Medicaid, there's a hard cap at 5% of your annual income that you can't have cost sharing more than that for somebody on Medicaid. So that's kind of a twisted way to get to, you absolutely can shift that 100 to 138. You could do it below 100% as well if you wanted to go and put those individuals on a marketplace plan or on a managed care plan.
Okay,
Follow up.
Thank you, Mr. Chairman. In Oklahoma, do we have an estimated number of, when we're talking about our population up to 138%, what that number is between 100 and 138?
Ta-da! Excellent question, Senator David.
Great lead.
Excellent question.
Thank you.
So the data that's provided here really is it's per the American Community Survey, which is a product of the Census Bureau. It's not the census, it's not 10-year census, it's a 1% sample, so that's why you get the rounded numbers. They're extrapolating data. But it is Census Bureau numbers that says, simply based on where people exist now and where they claim their insurance coverage is now, the estimate is that 216,000 currently uninsured Oklahomans would become eligible if we were to exercise the authority to expand all the way to 138% of poverty. Within that, there is a woodwork effect. That's the term that a lot of people have become comfortable with. That's the currently eligible for Medicaid. You are currently eligible, you're just not enrolled. As states in the past did outreach for marketplace enrollment and the new law was passing, different states have done different marketing and advertising campaigns. They saw more people come out of the woodwork and become eligible that were currently eligible. So to Representative Fugate's point, those people actually aren't qualified for the enhanced match. Those are old match. They can come on today. The 111,000, this is the group that, as you see the umbrella over there on the right, the orange is the 111,000. So that's the childless adults from 0% to 100%, age 19 to 64. They don't have a pathway to a subsidized insurance premium or Medicaid currently in the state. So they fall in this gap, in this coverage gap. They could, of course, get insurance through an employer if they have access to that. At that low of income level, it's very likely that they are part-time, not in the potentially the number of hours that they work, but in their employment status, so they'll have multiple hourly jobs that don't afford them access through their employer. So the other piece that's in that 111,000 is the parents that are above 45. This says 43. This is a national slide. Above 45% of poverty, up to 100% of poverty. Those parent caretakers, 19 to 64, are in the same boat as the childless adults. They don't have access to a premium subsidy through the marketplace. They don't have access to Medicaid currently. And likely, we're seeing that they don't have access to employer-sponsored insurance. And then to Senator David's question, currently around 85,000, in between 100% and 138% of federal poverty. That number is not reflective of who is on the marketplace. This is a number that truly is, these people are uninsured. And so they are not on the marketplace getting a subsidy right now. They are in that gap. They're eligible for a subsidy. They're just not exercising that authority. And so that gets you to the 216,000 that are potentially eligible that are currently uninsured. That number is more of a framework and less of a, this is my guess of who would come on if the state were to expand Medicaid. No state has had 100% take up, even the ones who are early adopters. I wouldn't expect it here. And you would see some kind of shifting around of the marketplace. Those individuals who are insured through the marketplace potentially would come off. To Senator David's point, should the state try and keep them on? I think that's a policy decision and pathway that we can definitely explore. I think there are some advantages. What you then get into is churn in between marketplace and Medicaid, or potentially how to figure out, okay, if you're bouncing in between seasonal work and you're falling in and out of Medicaid, is it better for you to be able to stick on a marketplace plan? All of those questions are kind of out there. So it's important. This is not a projection of who would come on in a Medicaid expansion. This is who is currently uninsured that would be eligible if we were to expand to 138% of poverty. I'll put this last one up, and then we can take questions. This is just a map, Idaho, Utah, and Nebraska. That lighter blue color signifies that they have passed Medicaid expansion, all of those via ballot initiative, and it has yet to go into place. So it has passed, they just haven't, it's not on the ground yet. Dark blue is expanded, orange is not, and it does not draw out the dynamics that we talked about before of some of these states cover adults at higher poverty levels than the state of Oklahoma does. For the most part, states cover about what we do, which is the minimum. So that's where this 43%, that's the median Medicaid eligibility limits, that's around the national average because it's the minimum. You can't go below that. And so that's where we are. But this map does not reflect Wisconsin, which I mentioned before, who covers adults up to 100%.
All right. Secretary, I had promised him that he could leave 1 minute ago, but I'm going to allow
Nope.
my co-chair to ask.
I've got 3 minutes.
Co-chair to ask a question, then I may have a follow-up, and then we're going to have to break and honor your time.
Okay, very quickly. Thank you, Mr. Chairman, and thank you, Secretary, for being here.
You bet.
Okay, so I think it's a point worth reiterating and kind of redoubling down on. Traditional Medicaid population and the Medicaid expansion populations are two separate populations. To me, Medicaid expansion is kind of a misnomer because we are not expanding the traditional Medicaid plan. So what other states have done. So what you're expanding is the use of Medicaid funds for a new separate population. I just want to make sure that, would you agree with that?
I think that both pathways are available to the state.
Yes.
That you could, if you wanted to, expand traditional Medicaid up to 138% of federal poverty. I can safely say, from the governor's perspective, that is not an option in this state. But yes, I would agree that you can take Medicaid funds, to Senator David's point, to your point, and utilize them for different coverage options.
All right, so I will ask this number 216,000 that you have. Every press report that I read, over and over and over again, the expansion, they say that we're going to provide health care to over 600,000 people. You seem to be saying it is less than 250,000 people. Can you explain why one of you is very, very wrong?
So the biggest caveat to some of the larger estimates really is the premise that if you were to expand Medicaid, that every employer that has employees under 138% of federal poverty would drop that employer coverage for those individuals. Other states have seen a move from the private sector from the private marketplace, the healthcare.gov federal marketplace. That move is a product of the fact that you're no longer eligible for the tax credit, not a product of employers dropping coverage. Other states haven't seen the employers wholesale leaving the private market.
So the difference between the 216,000 and the 600 and whatever the other number is that other number includes people who already have insurance, and states across the nation who have done this before us have not seen those 400,000 people show back up on the rolls. Is that
That's
what you're
correct.
saying?
And I think that's kind of, you can infer some of that from this slide that really is their employer market is healthier than ours, and a vast majority of states have already expanded Medicaid. So if that were true, that would show up here in a lower employer number.
Thank you. It's 10 o'clock. I know there were multiple people with hands up. If you have questions, first of all, you probably know how to get hold of the Deputy Secretary. If not, I'm happy to relay any questions that you may have. But
I'll be back this afternoon.
And he'll be back in the room this afternoon. So with that, thank you very much. I'd like to very briefly introduce the next speaker and let him introduce himself more than I'm going to introduce him. I do want to, a couple of caveats. One is He's going to cover a lot of ground. We are going to wait until he is finished with his presentation, because odds are he's going to answer a lot of your questions as he goes along. But please keep track of your questions. We will have a lot of time after he is done for questions and answers, and I very much hope that there are a lot of questions. Also would like to thank the Foundation for Government Accountability. Representative Tom Newell, I don't know if it's a representative or former representative, worked with him and worked with the Foundation for Government Accountability. They actually made it financially possible for our next presenter to be here, so I wanted to thank them for helping out, for getting us the best information that we could on this subject. And so next presenter is Clay Ferris from Mostly Medicaid. He has worked with the federal government and state governments on, well, a lot of different Medicaid topics. He has a Master's of Health Policy from Johns Hopkins Bloomberg School of Public Health, and that is the brief intro that I will give. As you dive in, if you would kind of let us know, I know one of the questions is what states have you been active in and kind of worked with? Because every state's got a different model, and so if we can kind of get in our head what models you've been a part of, that probably helps us going forward with that. Thank you for being here. Thank you for hopping on a plane early, getting off, sprinting to the building, and the floor is yours. And again, just very much appreciate your willingness to be here today.
Thank you for having me. It's an honor to be here from the great state of Alabama. War Eagle, for those of you who follow miraculous football. I'll give you a little bit about myself, because it'll help make sense where I'm coming from and why I have what I think is a somewhat unique perspective in this space. The summary I will give is that I eat, sleep, and breathe Medicaid. And I've been doing that for about 15 years. So I write about Medicaid on a weekly basis. I do multiple webinars where I have audiences come and listen to former Medicaid directors or other consultants or other just folks who have been operating in the space for a while to talk about what's going on nationally. So I talk about what's going on in different states every week, and have been doing that for quite some time. I sort of stumbled into this. I was working after I left Hopkins. I went to Medicare. Was at Medicare for a little while, then went to the state of Georgia, worked for the state of Georgia as a state employee, and had a lot of energy, started writing about Medicaid in this newsletter back to all of my Hopkins Public School of Health friends, and I said, hey, this Medicaid thing is way more complex than they told us in that 2-hour class we had, right? So that grew into a newsletter, and the next thing I know, there's a few thousand people reading it. The next thing I know, conferences start calling. They ask me to speak, and then after doing that for a little while, the next thing I know, it's turned into a consulting business, and now fast forward 15 years later, and it's a pretty unique, but something I enjoy very much, and I'm able to speak from a perspective. I don't work in a health plan. I don't work in a large technology company. I'm able to really kind of say what I think about Medicaid, and that's what I do all the time. So I encourage you to sign up for the newsletter. There's lots of free, great stuff if you're not already on it already. I know there are some folks that work for the state of Oklahoma that join the audience. I don't know about in the room. My goals for this session, hopefully these are appropriate. I believe they are based on my work up to this. My number one goal is for you to understand why other states use Medicaid managed care to deliver their program. And I'll kind of come back to that in a couple different ways. We're going to cover a lot of ground. Hopefully you will walk out of here feeling very confident in understanding the overall scope and industry and financing and issues and challenges in Medicaid managed care. I want you to become familiar with the model itself, with the landscape, the big players, how it's sort of segmented into different pieces. Familiar with key themes in recent state Medicaid managed care procurements. This is always the best place to go to see what the latest, greatest is from your state peers of what they're asking their Medicaid managed care plans, which I will soon start saying MCO if you're not familiar with that acronym, to mean Medicaid managed care plan. Those RFPs are good things to look at for what they're asking and expecting and believing that MCOs can do for their program. And then I also want to talk about, I want to kind of land the plane with some lessons learned about making a smoother implementation. Because you would be, if you decided to go down this path, you would be like North Carolina is right now. You'd be bringing it to your state versus perhaps transforming an existing program. A couple of quick assumptions. I'm going to assume that everyone here is somewhat familiar with Medicaid, but not Medicaid managed care. If that's wrong, somebody please raise their hand and say, Clay, we get all that. I will do a quick overview of Medicaid to kind of level set how I look at it, but it'll be less than 2 minutes. A note on figures, the nature of such a gigantic program, there are usually multi-year lags on figures and a lot of complexity. So I'm doing the very best I can to give you an order of magnitude approach. I'm more than happy to go into more detail. And you will also see, if you don't get the slides, you'll also see my email throughout. You can ask for more information. Acronyms that are important, there's more than this in this presentation, but a couple that I'll use over and over again. MCO, Managed Care Organization, just a Medicaid health plan. MMC, Medicaid Managed Care, the model itself. SDH, Social Determinants of Health. That's something that MCOs are being asked to impact more. If you're not familiar with this, this is the idea that food, clothing, and shelter have more of an impact on health care outcomes than health care itself, and that's a big part of what's going on in Medicaid managed care right now. Value-based care, value-based purchasing, for all practical purposes, just cross that out and think pay for performance. That's highly simplifying. There's lots of consultants that would kill me for saying that, but just think that. IDD, intellectual developmental disabilities, and MHBH is mental health and behavioral health. All right, so this is what I'll come back to over and over again. But I want you to get the main point first, or my main point first. These are the summarized reasons that I see states using Medicaid managed care, and these are their expectations, and these are what they're hoping that they can do, whether that is bringing on a new plan for the first time or renegotiating a contract in their renewal cycles, and they largely fall into these buckets. I'm going to emphasize a few as we go throughout. One of the bigger ones I'll emphasize is quality improvement initiatives. There's a lot of things that are possible when you can focus in on how one particular health plan is performing across a set of particular quality metrics at the population level. And I'll show you some good examples of states doing that. Budget stability is a huge reason that most legislators are looking at this across the nation. That's one of the main reasons that we get into managed care in the first place. At least a predictable spend, something different from what we've had. Transferring the risk, just conceptually, moving from all of the risk being on the state and federal taxpayer to some of it being in the private sector, and then enhanced governance opportunities. You can see there's a lot of other things on the slide that I'll hit on, but you do have more, because there's federal Medicaid managed care regulations, you do have other opportunities to insist upon a better outcome with these private sector partners. What is Medicaid? So I'm going to give you Medicaid in 2 minutes or less. Public health program provides medical services and drugs, disabled and poor beneficiaries. There's minimum things you have to provide to get that federal match. There's a lot of discretion on other things funded by state and federal taxes. In 2010, it was 21% of state budgets. I've got other numbers in here. I think it's higher than that on average now. Here's how it works in 2 easy steps. This example is in Texas. You can just substitute Oklahoma. Taxes are collected. Some go back to the federal government. Some come back. This is the federal match used to pay for health care and other things for Medicaid members, and then the state will pay their share. Quick history of Medicaid, because it kind of plays into where we are with managed care. Began in 1965, same time as Medicare. It was the last state to adopt, so Medicaid is an optional program. The last state to adopt it was Arizona in 1982, which started with managed care. So a lot of our data around the managed care experience, the longest piece of study we have on this is Arizona. And then 40 states have Medicaid managed care. North Carolina has added this year. If you've been following that, I think they're actually pushing the delay related to some getting appropriations for startup funds, but they will become the 40th state to add managed care. This is a chart that tells a lot. So this is all Medicaid spending through all time. You won't see this chart anywhere else. I'm the only person I know that looks at the total spending. I think it sort of speaks for itself, but I usually bring it to put it into context in these types of situations to show the overall trend. And you can see in the first 50 years of the program, this is all state, federal dollars, all programs. There were about $7.2 trillion spent from 66 to 2014. By the time we close out 2022, we're going to have spent almost as much in 8 years as we did in the first 50 years. So there's absolutely a trajectory here that cannot be ignored if we look at a longer picture. At the population level, I heard some discussion with the last speaker about thinking about the different populations, the expansion population being different from others. Very, very important to think about populations and subsets of populations within your program, and you'll hear that from me today. This is looking at changes in per year per member spending by the major breakouts. So for the aged, the disabled, the kids, the healthy-ish this and the new eligible. So this would be the expansion population we're talking about. Again, just showing that this has to be managed at a population level. The trends are happening at a population level. And again, I'm more than happy to make sure you get this information if you want. I know I'm covering a lot of information. The other thing, you're probably familiar with this, Medicaid does crowd out all other priorities. If you just look at what went up and what went down in a 14, 15-year period, I won't go through each of them, but the only one that went up in here is Medicaid, unless you count other. Everything else went down. This is based on state categorical spending. And it is growing. I think one of the things, when I worked at CMS, CMS is the Center for Medicare and Medicaid Services. One of the things we always joked is that Medicaid was the silent M. And I don't think it's that way anymore. I think it started out smaller, so we've kind of been somewhat surprised and overtaken where the growth trends are. So that's Medicaid. I know there's a lot of other things to talk about, but I think that kind of sets the table for the rest of the discussion, which I'm going to get into Medicaid managed care. So what is Medicaid managed care? In this, I'm going to cover managed care versus fee-for-service, defining managed care as risk-based, spectrum of care models, what states are doing in recent years, basic operations. Sometimes I think it's underestimated what all a health plan does. And then financing, some things around capitation and MLR. Some folks in the room will know exactly what all that means. Some folks won't. I want to make sure everybody gets that. And then I'll talk more specifically about populations included. So there's two main ways you can deliver your Medicaid program. One is fee-for-service, and one is Medicaid managed care. And on the fee-for-service side, you do everything. Or you piecemeal contract out or stand up your own in-house solutions to do everything. That's everything related to your providers, enrolling them, credentialing them, paying them, negotiating with them. That's getting them in the network itself. That's all your member services stuff. That's every single coverage decision in one fashion or another, and then that's also quality management for how you have to report back to CMS, how different parts of your population are faring under your program. And in this model, the state and federal government has all the financial risk. In Medicaid managed care, you port as much of that as you can over to a managed care organization, to an MCO. And you're still going to, hopefully what this does is put you in a position to do more oversight function versus the delivery function. There's a lot of things you probably will never let go of or let go to an MCO, particularly the eligibility piece that's usually handled separately, not enrollment, but eligibility. And in this case, ideally, the MCO has all the financial risk to deliver whatever you've defined as the benefit. And I'll talk about lessons learned about maximizing the chances for that situation later. But that's the two main paths. And when we talk about managed care, at least folks like me who study this broadly, we always mean at-risk capitated managed care. So this is something in which you pay Clay's health plan $100 per member per month, and you expect him to spend X amount of that $100 on medical services. X amount can go for administrative services, so for case managers or claim systems, those types of things. And then a profit is what's left over at the end. We do not, when we say managed care, and certainly at-risk managed care, we do not mean primary care or case management. I think you guys have one of those here. Great, wonderful programs, but that's all stuff that largely happens inside the PCP's office or patient-centered medical homes. When I used to talk about managed care, I've been talking about this for, like I said, the better part of the last 15 years, we would explain it as I just did, and they would say, and we also usually carve out your higher cost services or populations. So not putting foster kids in managed care, or not putting age, blind, and disabled in managed care, or certain behavioral health populations. That's no longer the case. We definitely see more and more of a move for states to say, okay, health plans, we think you can handle that population as well, and we'd like to see what impact you could make. Usually, you're going to have your low-income Medicaid population, the not as sick in this model, if you're a managed care state. And I already made the point that that's typically what we mean. A spectrum of models. I know y'all are looking at a lot of different pieces here, and I'm really going to focus in on Medicaid managed care. If you look at the more opportunity for value-based care or pay for performance, or basically if we pay more, we should get better outcomes. If we get worse outcomes, we should pay less. It follows this track. So in fee-for-service, you have very little opportunity to do that. That ASO is an administrative services model, which is they provide services where they'll pay claims. They might do some case management. It looks a little different. There's not a lot of them running around out there. Like a third-party administrator, if you're familiar with those. But you don't really have much opportunity to push the risk out or do value-based care in fee-for-service. At-risk managed care, with significant carve-outs, you get some more opportunity. Then you get, with limited or no carve-outs, you get the most opportunity. And ACOs, which are beyond the scope of this today, at least theoretically, you get more opportunity. And I can talk about those if you've got questions or give you my comments, but that's not what I planned on focusing on for today. What are states doing in recent years with Medicaid managed care? They're reducing the number of plans. This depends on your state. This depends on your geography. This depends on how many plans you already have or don't have. North Carolina going new, 4 plans, I think they awarded. Michigan has been trying to reduce the number of plans for years. 13 plans is just a lot to manage in terms of vendors. So they're trying to do that every time they go on these renewal cycles, which are every 3 to 5 years. They're doing value-based payments. So they are requiring their managed care organizations to put X% of their provider payments in value-based contracts. And I'll talk about that more when I get down into how this ties into quality. They are trying to impact social determinants of health. So I'll keep using North Carolina as an example. That's one of the states that I've done a lot of work in. And because they're the newest, and they are paying the MCOs right now to assess member needs. So Clay, are you going to eat tonight? Clay, do you have a job? Do you want help getting a job? Clay, do you have housing insecurity? They're paying the MCOs, the health plans, to do those assessments right now so that when they get done with all that assessment, they'll have a data set that says, okay, we have these 25,000 members that we want to spend this amount of money that we just got from CMS. They got $600 million from CMS to address those needs. This is separate from the managed care program. And then there will be another procurement let for providers to come along and create networks for non-traditional provider types. So food banks and social worker agencies and those types of things. So that's one of the things that they're doing. Provider-led entities, most of them, part of the deal that'll get struck a lot of times in making a new one or renewing is saying, okay, tell you what, it's not just traditional health plans that can get this business. We'll also open it up to basically a health plan run by a physician group or a hospital group. North Carolina does that. New York does that. A lot of different places allow provider-led entities to do that. They're moving away from non-risk-bearing models. There's some information in here in this deck that shows the states dropping fee-for-service, but also PCCM. They're reducing carve-outs. They're also putting up these Medicaid long-term services and supports programs. So it's people with long-term care needs. Usually we're talking dual eligibles, if you're familiar with those, Medicare, Medicaid dual eligibles. States that we've done some work with and have over the last couple of years that you may have seen, Virginia, they just stood up a standalone MLTSS program. That's things they're doing. You'll have a health plan to run that as well. They're trying more and more to get health plans to do behavioral health and physical health together. So meet all the needs of Clay as a person, even though I might need a physician to do this thing and a counselor to do this other thing, but have a health plan coordinate all of those needs together. Arizona is a great example that recently just moved several 100,000 people in last October into an integrated care plan. And they're starting to increase the focus on fighting Medicaid fraud in the health plan space. That's, again, a whole other topic. If you're interested in that, my weekly Medicaid roundup ends with Ferris's Fantastic Fraud Follies, where I write about Medicaid fraud every week. I could write about it till the end of time. This is, I won't belabor this. This just shows you percent in any type of managed care. has been around 70 to 75% for a few years now, but we also see the maturation into the risk-based managed care. Like I said, a lot of these numbers are going to be several years old, but this is from a really good HMA white paper out there. I can send you the link if you like. And this is sort of more data on the same. This is a picture of enrollment in managed care over time. So you can see with the total Medicaid being the blue bars and the yellow being those that are in risk-based managed care, you can see the trend absolutely is to manage the needs of those members in risk-based managed care. This is just a visualization of the states that do or don't have managed care. You can see on the right-hand side, most of them in Medicaid managed care. North Carolina will move over to this right-hand side. Alabama tried to do it a couple years ago. I was pretty involved in that one, if you want to talk about that one at some point. They tried to do it with the RCOs. It was sort of a failed attempt, but I think we'll probably see another attempt in another few years. This is a map to show you, this is sort of a heat map of what percentage of their members, of those that have managed care, what percentage of their members do they put into managed care. So you can see 10 states put almost all of them, 90% of their members. There is a little bit of a spectrum there, but that's how I think about this, and we definitely see that trend to put more and more and more into managed care. All right, so let me take a little bit of a pause. Let me get some more water. So that is the biggest, the best way I can compress what other states are doing. I'm going to hit on more detail later. But next, I want to talk about what an MCO does. Again, I think a lot of folks don't realize what all goes into that. Can you hear me okay without the microphone? No? You got to record it or something? Yeah, okay.
We're live streaming.
Thank you.
There are people texting me questions to ask you from the live stream, so.
Thank you.
But you can, you'd asked before, feel free to take that microphone out, pace around if you need to,
I think I might.
Works for you.
It'll wake me up a little bit. I apologize. I've been going since about 1 a.m. So in this section, I'm going to give you an overview of managed care itself, the Medicaid managed care model, the core MCO functions, the typical services that states find amenable to have an impact on managed care. You really need to think about that, what you really think will have the most impact. And then the complexity, I'll spend just one slide on the complexity of the Medicaid provider network. So we do a lot of training as well, and each of these topics are things that I find time and time again, people underestimate what all goes into it. So this is as simple as I can get it. So a state will contract with the insurance companies, with the MCOs, and they will negotiate capitation rates, PMPMs. I'll show you how rate setting works in Medicaid, and when we get to the financing section. That's a fairly complex thing. You need really good actuaries for that. The managed care organizations themselves will contract with doctors and lots of other provider types. They'll negotiate rates for services. They'll get them enrolled in their network, and then the doctors will provide services to Medicaid members. They'll submit claims to MCOs who then pay them. These are high-level business functions within a health plan. And each of these, you're talking about a lot of staff resource to make sure it happens correctly. The biggest thing, in my view, that an MCO does, if you stripped away everything else, is the network. I mean, if we were building a house, they're a general contractor, and they're getting the plumbers, and they're getting the electricians, that type of thing. So if you don't have an MCO, you don't have someone that you can require to meet certain network standards, and that's where some of those other federal standards come in that I was talking about earlier. But they have to build a network. They have to have a certain type and quality of providers in there. They have to have so many per members and within certain time and distance standards. They have to do a lot of stuff with the members. So they have to get members enrolled. They have to do all the communications around them. A lot of times they'll be the one handling the cards. A lot of times they'll be communicating with them about chronic conditions. They have to do a lot of things with providers. They have to operate a line for providers to call. They have to get providers enrolled. They have to do all that negotiation even after they get them in. Depending on how it's set up, they're going to have to process claims or encounters. They're going to have to handle those complex prior auths. I don't know how you handle them today, but they have to handle, should even though Clay's kid really needs this MRI, it's excluded from policy, but we've got an exception process. How do we do it? They do all that kind of stuff. Grievances and appeals. That's a wonderful thing to take off your plate that they'll have to handle. Quality measurement and quality improvement, I would say that is the shining star of what you can get from a managed care organization. Care management, pilot programs, I mean, lots of different things. And this is highly summarized as well. These are the services. I want to talk about what you might consider having a managed care organization do. And hopefully the perspective you're getting is it's not just managed care. So, okay, what type and what will they do for us? Because you really do need to get that specific because every state is different and it needs to work for your program and your population. So I've created a high-level chart that buckets all the services into long-term care, that's really a separate thing, administrative services, and then everything else under acute care. And long-term care is shaded because, as I mentioned, states are having plans do certain things in Medicaid long-term services and supports programs, a lot of things. I think there's now more than 20 states that have a dedicated MLTSS program, but that's usually not what we think of. And then on the administrative services side, you're not going to give all that over. You're still going to do the oversight. You're still going to do a lot of other things besides that, but they will take on some of that, and that's what they get paid when we get to MLR, the types of things that go in their administrative numerator. But in the bottom is what we typically think of applying either utilization management or better continuity of care across these things. So an inpatient, how do we, Clay has had 3 admissions in the last year that should have been preventable for his diabetes. How do we get a managed care plan to help us do that? Or Clay went to the ER 36 times last quarter. How do we help with that? And that's sort of the picture. But the continuity of care is how do we stitch together how we have somebody doing effective care management, case management across all these different pieces of the needs to where they're not just siloed in inpatient, outpatient, pharmacy, and transportation. And transportation is a little different. There are, I don't know how you do it in here, but there are specialized companies that do non-emergency transportation, but sometimes you will have MCOs own that as well. This is my complexity of provider network slide. I think most of us, when we think about provider, we think about doctors, maybe nurses. But in Medicaid, it's pharmacists and physical therapists and ambulance companies and DME companies that provide wheelchairs and taxis. And Uber and Lyft in some states now are enrolled as Medicaid providers. And trainers. It's a very, very complex thing to have the right provider network. And obviously your healthcare delivery system is only as good as your provider network. And I think that's something that MCOs are very good at, and that you want to make sure that, that you get that value from it. So let's talk about populations in Medicaid managed care. I'll kind of show the major eligibility groups. Many of you are probably familiar with those, but I want to contextualize that for this. At its highest level, you've got 2 major buckets. You've got the sickest of the sick, which is what Medicaid started out for in 1965, the aged, blind, and disabled, the most vulnerable. And then you've got those that aren't quite as sick, but low-income Medicaid, so are in for income-based things. And they could be both. They could be poor and sick, and often they are. But when we talk about other groups, when you're having your expansion conversation or whatever, they usually look very different in terms of the risk profile versus ABD. Here's how it shakes out in population-wise nationally. So out of 71 million or so, about 28 million or so of those are kids in Medicaid. And then about 15 million are age blind and disabled. And I've been working on some analysis to show how many are in the LTSS programs. I'm not quite there yet, but just to think about which population you want to target and how. Here is the Medicaid managed care enrollment penetration rate. So nationally, almost all the CHIP kids go into managed care. You got 80% of them. In the expansion, 82%. They almost all go into managed care. ABD, we're now at 49%. So 15 years ago, this was more like 18%, to give you an idea of how much more comfortable states are in moving those most vulnerable members into Medicaid managed care. I'll talk about, what to expect. You'll often get, I'll still see the opposition thinking that, oh, well, we can't trust managed care with this population or that population. Well, other states have been trusting managed care with these populations more and more. And then you can see the total is about 73%. If you do carve out, these are the ones that are carved out. I've kind of mentioned those. Foster care is less and less carved out. There are at least 2 RFPs being bid right now, maybe 3 just for foster care. And there've been, in states like Washington, there's been foster care, managed care for a long, long time. If you're not familiar with this chart, this is the one that reminds you that most of your enrollment does not account for most of your spending. So you want, if you just give an MCO your healthy kiddos, you're not really necessarily maximizing what you could be from a financial impact and even from a care impact. But it is more complex. So for example, the disabled are 15% of enrollment, but 43% of spending. So what you really want, if one of the main priorities you have here is budget stability and predictability, you really want MCOs that can demonstrate, yeah, we're really, really good at bringing down this cost for that and improving this metric in your elderly population, that type of thing. It's not terribly hard to just do healthy kiddos. I'll talk about financing. Couple of key items here is capitation and the medical loss ratio, which are pretty closely related. And I'll talk about rate setting and risk adjustment. This can be one of the really challenging parts of all of this, and I'll kind of give you my thoughts. I have worked with most of the models that are out there. So capitation is pretty straightforward. It's what I was talking about earlier. You give Clay's Health Plan $100, and you say, out of that $100 for this month, 88. Say you've got an 88% medical loss ratio, $88 need to go to healthcare services, and then the remaining $12 are administrative cost and profit. And if you get specific, like most states do, and you say, and by the way, we're going to cap your profit at 2%, you can put in, boundaries on that. Then that leaves, 10% for all the administrative costs. And there are certain things, these are federal criteria, there are certain things that can be included in that numerator and certain things that can be included in the total part. They can't just claim, oh, well, this is administrative or that's not. So in an example, let's say there is a health plan that has 100,000 members. So a small Medicaid health plan will have 50,000 members. A large Medicaid health plan might have 1 million, if you're looking at some of the plans out in California, and then everything in between. If you have 100,000 members, and let's just say this is all kids, $90 per member per month, that's going to translate into $108 million capitation revenue a year. 85% or $92 million of that is going to need to go to healthcare services. If you cap them at 3% profit, that's $3 million they can make, and that's $13 million they can use to deliver all this stuff besides what they pay for providers. And that's a total budget of a little over $1,000 a year for that member. And you're going to see this different depending on the rate cells. And I'll show you some examples of this in a minute. So here is how Medicaid rate setting works at a very high level. The most important thing to realize, if anybody in the room is familiar with how Medicare rate setting works, it's not like that at all. So Medicare rate setting is at the individual level. Medicare rate setting looks at Clay's utilization data for HCC codes, for high cost condition codes, and says, okay, you cost about this much. Next month, we're going to update the premium we are paying for Clay Ferris to Blue Cross Blue Shield or whatever your local MA contractor is. And it can change on a monthly basis, and it's at the individual level. And there are whole companies that go in and help plans find some of that data that may be missing to get those individual premiums upped. In Medicaid, it's done in aggregate, and it's done at the category level. So for me, my rate cell would be a fairly healthy male, between 38 and 54. And for everyone that falls into that bucket, the rate will be paid to a plan, $200 a month, whatever that is. So a member, how all this works on the Medicaid side is a member receives services that goes into the data stream. All member claims are aggregated over 12 months. Some states update rates quarterly, most are annually. Actuaries will then run an actuarial model, and there's 3 or 4 main ones. Most of them use one called CDPHP. But they will run the model. They'll do very, very complicated math, and you'll have your own actuaries, and the MCOs will have their own actuaries, and somebody else will have actuaries. And they will come up with, okay, well, here's what it is based on the risk and the health profile of what's in the population. And then other adjustments will happen based on, okay, well, in this region of our state, it's harder to get providers, so we need to pay a little bit more here. Or in this region of our state, they're not really as sick as they're showing up over here. So, or Medicaid program changes. You know, we're going to implement a new diabetes prevention program or a new pharmacy lock-in program, and we think that will save $30 million next year. Well, that has to go back into the model. So all that is done, and then it gets sent to CMS. All this has to be certified by the CMS Office of the Actuary. There's a whole process related to that, which just got a big update about 3 years ago. And it all has to meet this actuarial soundness criteria. So that is how Medicaid rates are set. There's lots of places, you know, this is a very complicated chain. There's lots of very important things to get right. It's nowhere near as simple as I'm showing you, but I want you to kind of understand if you find yourself starting to get into those types of discussions. Here are typical rate cells. These will be state specific. They usually follow your eligibility categories, but they will be, okay, for kids this age. Infants are going to have, you know, a higher because you got all those initial visits you need to do. TANF is usually one. You may have one specific for each of your waiver programs. This is something that it ties to the program, whatever you're doing in your program. Usually they follow the traditional, somewhat uniform eligibility categories across states, which would be these types of things. All right, so that is sort of the basics of MCO operations, rate setting. How are we doing on time? I had set aside about half an hour for questions or so, and I think we've still got a good bit to cover, but I think we're going to have that time. So I want to talk about the market landscape. So the business of Medicaid managed care. I want to talk about some plans and who has what market share. That's a lot of financial information. One of the things that my firm does on a quarterly basis is we put out market intelligence products specifically about the business of Medicaid managed care. So I'm going to share some of that from there. But I'll talk about the segmentation. So not all plans are the same. There's some plans that just operate in one market. There's some plans that are operated by a children's health plan just in one market. There's some plans that operate in 4 or 5 states, and there's some that are in 20-something states. I'll give you an idea of how much percentage of the Medicaid spend is going in there, and we'll profile some of those national MCOs. So here's another, whatever you call this chart type, nested chart, just to kind of show you roughly $160 billion. It's more than that now. This was 2015 or so data of all Medicaid spending. Is through Medicaid managed care. And Medicaid spending is more than $500 billion now. We're probably pushing $600 billion when the newer numbers come out, I think. Medicare and Medicaid together, a little over $1 trillion, and all of U.S. healthcare, about $4 trillion. Just to give you a sense of where within this Medicaid managed care is from a cost perspective. At any given time, there's about 300 Medicaid managed care organizations. Now, some of those are 30 different flavors of Centene in different markets. Some of those are, like I mentioned before, standalones only in one market. But in terms of unique health plans in markets across the nation, anywhere between 250 and 300 MCOs. About 30 million members. And this part here is really the most interesting part of the slide to me. You can see what percentage of all Medicaid payments have been going through Medicaid managed care, and look at the walk up. So in 2007, you've got 20%. All the way up to last year, you've got 53%. So this gives you a general idea of where your state peers have been going in terms of the spend. The revenue per member per month, those rate cells, anywhere from 90 or so, 150 so bucks to $2,000 plus. So if you've got an LTSS program, you're going to have members with very, very intense needs, and you're going to be paying thousands of dollars a month to the MCO to hopefully manage it better than has been without them. And most are looking at a pre-tax margin of 2 to 3%. The segmentation, you got the large nationals, all the ones whose names you probably know. WellCare, Molina, Humana, United, so on and so forth. And they'll be the ones that are really successful in multiple markets and in what I call the mega markets in New York, California, Florida, Texas. You have the local regionals. You've got plans like Tufts or Trusted Health Plan. They're in a couple different markets that are trying to kind of make a way for themselves. And then you'll have major regionals like CareSource, if you're familiar with them. I think they're in 5 markets now. And then the one-offs. And you'll see these, if you're looking, what I call the one-offs are usually nonprofit plans. You know, they're usually focused on one, often on one particular population in one market. This data is now 4 years old, but you can see how many millions of people are served in a Medicaid program across the nation. So, for example, Anthem had about 6 million Medicaid members 4 years ago. And they've continued to do well. Aetna, I think, is now below 1 million in the latest data that I have. So you were talking about operations that are serving an astonishing amount of Medicaid members, at least across their enterprise. And these are some of their financials. This is something that I put out in the Medicaid Black Book every quarter. We go into a lot of detail about each of their financials. But just to give you a general sense, the revenue, the profit, and the EBITDA is on here. Some of these are just absolutely amazing in terms of the financial, what is going on with these. It gives you a sense of how large they are. You know, you got United with $60 billion. This is a quarter. So knowing the financial health of your potential plan partners is pretty important. And you'll actually see a lot of states now in the procurement cycles not sort of risking it. So, for example, in what's going on with Kentucky right now, it's another one we've been involved in. Passport Health Plan basically had to sell a 70% stake to Evolent so that they would have the reserves to meet the bidding requirements to show financial solvency. So I'm going to start to bring more of this together and come back to the idea of the reasons states use it. You've heard me kind of give the overall example. I will get more into the quality and the withhold piece of this. I want to show you some examples in Ohio. I want to show you how specific you can get with your plan partners for quality improvements. This is the same slide you saw before, but just as a reminder, we're looking for, if we're a state, we're looking for health plans to improve quality. We're looking for some budget stability. We're trying to get rid of some risk, and I think we're really looking for enhanced governance opportunities. And this is just the main idea. In the fee-for-service, you know, that's real. There is no distribution of risk beyond the public sector. And ideally, in managed care, more of it goes to the MCO and it goes to the provider. That's what you see in markets like New York Medicaid, which required 90% of managed care payments to providers be in some sort of value-based arrangement. As far as the budget stability side, there's a lot of different studies out there. This really comes down to your state, and you have to do very, very specific models on that. And I recommend getting very, very specific. There are some challenges in states like Iowa where there was just high-level savings numbers put out in the beginning, and it just didn't work out well. I highly recommend your own in-depth analysis, and if you get to a point where you are bringing on MCO partners, have them provide to you their own in-depth analysis of exactly where and what they're going to save. So, I mean, the savings are, if you look at places like Pennsylvania, very possible. They saved $6 billion over 10 years compared to fee-for-service. AHIP has gotten, the American Health Insurance Plans, they've gotten pretty interested in showing the use of managed care on the pharmaceutical spend, because this has been, if you track what's happened with, say, Hep C drugs, other specialty drugs, oncology, and Medicaid, it's really kind of surprised a lot of states, and they have this gigantic expense they weren't planning on. So there are now studies that show how not just savings, but how much savings Medicaid managed care can provide on the pharmaceutical side. And Lewin, one of the more famous studies of this is Lewin Group. I think they updated an older one, and it shows, up to 20% depending on the states. So again, This is something that you should be expecting from MCOs and also have a very, very specific analysis for that. Let me talk about value-based care, and I will move into some quality metrics in a moment. So what does it look like in Medicaid today? In a Medicaid managed care organization, it's basically a withhold. So Clay's health plan is going to have to hit certain quality numbers, and if he doesn't, you're going to take away 1% of his capitation. And that can be, as you'll see, in the millions and millions of dollars. You can call them bonuses, penalties, however you want to frame them, but that's basically how it works. You can also do auto assignment, meaning the higher quality plans will get more members, get more enrollment, so more possibility to make some money. For members that don't shop or select in, a large portion of members just get auto assigned. And most states do the former. Most states do the withhold. Washington and California do the auto assignment, and that really matters in a place like California where you've got millions and millions. And you'll see in a map about the increasing push of provider payments. The ACOs are on here. This is a slide I've used in a couple different arenas. So these are just examples of what different Medicaid programs are doing in managed care around withholds and value-based care. California is plus or minus 1% auto assignment if you hit 5 specific HEDIS measures. I'll show you what those are. HEDIS is just health, I think health and employee data set. It's the most well-known in the space quality measure set. Missouri does plus or minus 5. I think it's 3 HEDIS measures and 2 operational performance metrics. Florida, all the ones that I know of do some type of plus or minus based on performance of certain metrics. I haven't seen one not do that in years, and I think it can go up to 8% in some of them. Yeah. So Missouri is the example I gave of the predominant model up to, they're 5%, but in this model that we'll see nationwide, it's between 1% and 8%. And then Model 2 is the auto assignment with California, Washington, other states as the examples. These are the types of measures that I most commonly see tied to money for health plans. So well child visits, if you're not familiar with that, that's a very important thing in care for pediatric populations. Tracking, making sure we're getting all the shots and tracking development, and there's a lot of them that are required depending on the age. Immunization, we talked about that. ADHD meds, lead screening, this was big in Flint, Michigan. And then for the adults, you're usually looking at something related to diabetes, possibly related to mental illness. State can choose whatever they want. There's hundreds of measures you can pick from, but most states end up picking from the same dozen or so. All right, so this is from Ohio. I've done a little bit of work there as well. And they're really good about reporting out this system. So each year they put out a pretty strong report that shows these types of things. So you can see which plans are getting better overall, which ones are going down, where they fall in the performance levels, as well as how much money they got out of the possible. So in 2017, they got 33%, which was $47 million that was put on the table in this value-based arrangement, out of 143.8 million. And in 2018, they got more of it. They got 43% out of 153 possible. And this is to show you by the measure where their performance standards are. This is to show you a particular measure. So in this example, Paramount is the highest performer, 61.6%. So I'm going to guess they got most of the payout possible on that one. Buckeyes improving year over year. Molina's going down. United's going up. Statewide's going up. So on and so forth. The main point is here you can get very, very specific. This is not possible in a fee-for-service program. In a fee-for-service program, the most you can do is give provider incentives that we hope will do something. I mean, I know that's my particular view. You now have a partner that you can get very, very specific with. Here's another one, just to where you can see, and this is on an annual basis, the granulation possible. And you can see over time it is moving the dial. I mean, there's fluctuations, but in both of these sets, which is all measures and just the pay for performance measures, we're seeing improvements. These are all things that will tie to federal regulations, the network adequacy, the MLR, PI, the external quality review. These are all things you can use to your plans are beholden to them at a federal level, not just at the state. Let me show you a couple quick RFPs. I might just do two, just in the interest of time. So North Carolina, RFP was fall of last year. They're implementing now for the first time. They're starting out with 27 counties. So you don't want to do it everywhere. You want to figure out where you're going to do it first and then roll it out after that. There were 4 winners. Notable scope, I mentioned the assessments for social determinants of health. They also have the provider-led entities. And if you've been following North Carolina, they have these historical mental health entities, which are sort of like mental health MCOs. And it took them a couple years to figure out what to do with those, these legacy mental health provider health plans. But now they basically become subcapitation to the MCOs. Louisiana, it was awarded. It's now in protest. There will be protests. Go ahead and prepare yourself for that. If you do an RFP, there's no way to not happen. And I'll talk about an RFP versus an RFA. 4 MCOs, Centene and Aetna lost. They're protesting. You can see the populations they moved in. And they will all score them differently. But again, they are looking at whatever the latest RFP was. It kind of uses a starting point because that's what kind of represented the best practice in Medicaid managed care procurement. If it required special CMS approvals, it got CMS approval. So the ones that Minnesota's in your packet or in the slides, so is Kentucky. Here's some upcoming ones. So Ohio's probably going to be early next year. Hawaii, I think, dropped last week. And then California is a big one that everybody's watching for next year. Let me do lessons learned real quick. So typical challenges, which is where we learn the lessons, right? These types of things. So it's not a given that an MCO can come in and do what you want to do with network. Right now, Kansas is struggling with Aetna, right? Usually that's kind of an unusual thing. I haven't seen, that's not the norm. But there are some pretty interesting stories right now with Kansas and Aetna, because they're not meeting the requirements on the provider side. There are new CMS requirements about getting provider directories up. Used to, a plan could once every year or so kind of put up a somewhat accurate listing of the providers, right? Not anymore. CMS is now requiring that to be much more real time, much more accurate. So those can be challenges. You're going to have provider opposition that just makes sense. The risk adjustment can be difficult. There's that historical skepticism of access problems for your most vulnerable population. As I've said, I mean, yes, MCOs make mistakes, but I have only ever seen it actually really improve access for any of the populations. The system cutovers are where the real hiccups are going to be. When you first do this and providers are getting used to billing a new payer, that type of thing. The protests, there are no RFPs that I know of in the last 3 years that haven't been, whoever the losers are, didn't protest. The pharmaceutical management, there's now a lot of new things for us to worry about on the pharmacy side, whether or not we do managed care. Specialty drugs, the drug rebate program 340B. The plan consolidations make it interesting. So North Carolina is an interesting case in which they awarded 4 plans. 2 of them are now merging. So if you were trying to do, that's Centene and WellCare. And then the length of time for budget stability. I want to put that on there for this particular group because I've worked with budget cycles, I used to do fiscal notes when I was an auditor in Georgia for legislators. I know how kind of the frame is, but this is not something you're going to have everything you want in a year, right? It's something that's going to take, I can't give you an exact number, it's going to take 2, 3 more years. So I recommend some sort of plan going in to where your MCO partners are saying, well, here's where we're going to be in year 1, here's where we're going, so on and so forth. But just to set that expectation. I think this is the last I'm going to cover. By the nature of what I do, I know a lot of people in the space, and so I did a little bit of an informal survey of a couple of people that I really trust on in the managed care space. And I said, if you were going, I was like, here's what I'm doing. I'm going to speak to Oklahoma in a few days. If you were to get across to them a few quick points or tips or whatever you want to call it, what would they be? And this is kind of what came back. Comprehensive planning and readiness assessment for each phase. You're not just going to award a contract and it'd be okay. There's really a lot of extensive work that goes into all of this. And I've put up the major phases there. Don't do it all at once. Do it in phases. Pick a population, pick a region. The MCOs need to learn your program and your population. Every state is different. If you haven't heard this joke yet, give me the honor of telling you, if you've seen one Medicaid program, you've seen one Medicaid program, right? So they need to learn you and your state and your population, and you need to learn them. So don't, like I said, don't do it all at once. Invest in governance. This is basically a quote from one of the folks I talked to, but Medicaid managed care is the best of all options, but only with a very strong oversight capacity. The RFP versus RFA, not all states do an RFP. Some do an RFA, like Oregon, so request for application versus request for proposal. There are some arguments to be made that it may be a little safer in terms of lawsuits and protests, because it's not this specific framework which they can argue, which, you know, you did it wrong, you were unfair. It's sort of more broad and more objectives-based. And then the Ohio cautionary tale about the pharmaceutical side. Use the MCOs to help you manage that benefit. It always costs more to not do it. With MCOs, you've got to buy drugs for this population. You need a strategy. And that PBMs and things like spread pricing are a whole other conversation. Happy to answer questions about that. But it's also really, really challenging when you are making all these controversial decisions on your own without some other partner to help you with that. That's my information. Thank you. I'm happy to take any questions or not, whatever works for the group.
Thank you very much. That hurt my brain, so I think it must have been good.
And I have succeeded.
Representative McIntyre.
Thank you, Mr. Chairman, and thank you, Mr. Ferris, for flying here to give us this. Appreciate it. I'm going to ask a bunch of questions from a skeptic's point of view because they need to be asked. And so, you know, I'm looking at your total Medicaid spending graph that shows basically Medicaid spending since 2000 has increased 4 times. And I'm sure you're going to tell me part of the reason is because we have an increased number of participants and we have an ever-increasing cost of care in this country. And when you look back at your increased cost of care since 2000 graph or table, you see that on average it's about 1.5 times, right? And I agree, I get we're looking at the aggregate impact in your overall spending chart versus the increased cost of care. I just want to know, how do you explain that increased cost in spite of MCOs?
So I think that's probably kind of how we put all the questions together. And were you talking about this chart as well as the orange one?
Yeah.
So despite, in my personal view, I think the biggest thing is the overall price trends in healthcare, regardless of payer. I'm sorry. I think the overall driver of all of this is price, so provider price, whether that's a pharmaceutical provider, a hospital, or the physician or whatever. And there's a lot of other, in healthcare econ, there's a lot of other stuff that shows that all gains in wages have been eroded by healthcare, regardless of who. So I think that is the most, if we were trying to do an example, a formula of all of them, right? And then I think the bigger part in this chart is you almost doubled the program. Particularly from 2010 forward with the ACA, you went from 40 million to 70-something million. So I mean, in my view, between the price issue and doubling the volume, we've explained 90% of that trend, right? And then I think the managed care issue needs to be, I think it's a good question, and that's why I keep saying managed care is the way to go, but you gotta hold them to the fire, right? Like it's not just write a check and be done. I think that is a state-by-state question. I think that's a year-by-year question that needs to be asked over and over again. I don't think managed care can cover every sin possible when we're doubling the size of the population and that type of thing.
Follow up.
So I don't know how familiar you are with Oklahoma, and I'm kind of a Medicaid nerd. I like to read stuff a lot. And about 20 years ago, we tried an MCO model. It's in this Mathematica study that's a gazillion pages long. It was an abject failure. And my question to you, and if you even know, what has changed in Oklahoma to where an MCO model might work today where it didn't work 20 years ago? What has been, I mean, if you look at the Mathematica study, it looks at Florida, compares us with Florida.
Right.
They had they had a lot of HMOs and stuff infused into their system so they could handle it better, but we didn't have that. So I'm wondering if those challenges are still extant today and what you would say to that.
I think, and thank you for bringing that up, because I did do a little bit of research to try to at least get my head kind of oriented. I think, if I understand correctly, in that scenario, you had two plans, one of them exited and then it collapsed, right?
Yes, that's correct.
So, again, being very uninformed about that situation, I think that was the big risk point. Although states are trying to reduce the number of plans, I don't think anybody would want to go down to just one or be at risk of just one. And there's a couple of other, there's been some exits out of the Illinois market, which is a whole other discussion. It's one of those things, it's unusual for a plan to do it, because once they do it, they've burned a bridge and states hate them, especially that particular state. That would be my sort of initial answer without research, is get more plans next time. And other than that, I don't know. I mean, I also looked at a couple of other things. Maybe y'all have actually been down this path recently, managed care, and that was, I don't know if that got stopped and started or whatever. So I'd love to learn more about that. The other thing, the other kind of like, other, not rebuttal, but answer I would give is, I'm assuming everybody in here has managed care insurance, right? So it's not that managed care can't work. It's the question of, does the payer matter, or how many do we have?
And thank you. Sorry. Go ahead and recognize.
Go ahead.
Thank you, Mr. Chairman. So, and Medicare itself is, would you agree, is a managed care?
The vast majority, and especially as they, I actually got into this conversation on my webinar yesterday with the former North Carolina Medicaid director. Yeah, it's managed care, and it's becoming more and more managed care. It's only the older generation currently in Medicare that is not in MA, in Medicare Advantage. The younger ones, more and more.
Senator Haste.
Thank you, Mr. Chairman. And again, I also appreciate your presentation. Representative McIntyre mentioned this. I mean, and maybe he and I are a little unique here. When I start seeing $1 trillion, that becomes significant to me. I think it just scares me, when you look at that number. But I want to deviate just a little bit away from Medicaid for a second. I know a lot of conversations has been about Medicaid, but I also see the importance of this body to be looking at outcomes versus just focused on one area. As we look at the state, I think that's part of our responsibility. And I've been told that you may have answers to this. If not, we'll move on from there. But in a previous presentation the Deputy Secretary made, was talking about comparing us national averages on some things. In one area, we were below the national average. The other, we were above. One that we were below is the number of employers offering insurance, okay, health insurance. Then on the flip side of that, though, the number of employers that were offering insurance that had 50 employees or less was greater than the national average. Okay? Now, a part of that we believe is, the driver on that is Insure Oklahoma, which Oklahoma is very creative in creating that. So my first part of the question is, from a national standpoint where we're below the average related to employers offering health insurance, why do you see that, or what do you see is different?
Can I ask two questions to help answer that?
Sure.
So, one, I would ask, who are the largest employers in the state? And how much of that are we talking, like Walmart is a huge employer, or other retail?
Well, we have large employers. Tinker Air Force Base,
Right,
I believe, is actually the largest employer in the state. Yeah, we have retailers that are, we have, healthcare is a major part of our employee makeup in the state, oil and gas.
Right.
So those are all
But those
big
are,
drivers.
but they're going to have to be offering it anyway because they're above 50, so that's not, I'm just kind of thinking. I don't have a good answer. I mean, I think there's some of the answer is in the fact that it sounds like small businesses are generous here, right? So I would want to look at more, maybe even why that is, and build off of that. And my other question was, is the Sooner Care? Is that what Insure, sorry. Is that like the Healthy Indiana plan? Are you familiar with that one, where Clay kind of gets a health account? He's not normally eligible for Medicaid. His employer relates to the state. Is that different?
I don't think so.
I don't think that's the case.
I had read a little bit about.
I mean, it ties in with Medicaid and other programs.
Right.
But I don't have the specifics
Right.
of how that works. Okay. Follow up?
Yes.
So kind of moving over to where we're talking about Medicaid, we're talking about managed care Medicaid. First of all, in essence, we're talking at HMO. Is that correct?
Essentially, I mean, that term carries a certain datedness to, but yeah, that's roughly what we're talking about.
Right.
A health management organization.
Because
Yes.
sometimes
Yes.
names get changed of things
Right.
to make it seem a little better, or it didn't work in one area, so let's just
Right.
change the name,
Right.
and it'll sound better. Is that
I think that's fair.
okay?
Yeah.
All right. So with that, as we go back and we look at cost, keep going up. You know, again, obviously, like you bring more people on Medicaid and so forth, that raises cost. But also, you know, you got all the states have jumped into managed Medicare. You know, sometimes people take the path of least resistance. It's the easiest. That's what's out there. You know, as I look at us for Oklahoma, we were creative with Insure Oklahoma. I'm not always someone that just looks at, well, everybody else is doing it, we need to do it.
Right.
So I have problems with that also. But also, as we look at costs going up, one of the constants in this, because it's going up in drug prices, it's going up in health care. Well, the two constants in that have been added, that we've added more of through this process, we've added more states using managed care and PBMs. And both of those are supposed to drive costs down. So with that thinking, why is it the prices keep going up?
Well, I think particularly Medicaid, the sort of missing character is the member. And
I'm sorry.
Is the member. And the one thing we don't, it can be hard to talk about, but you know, when you have members that are utilizing at levels high cost things like ER with no incentive to not, that's completely different than you and I. If I go to the ER when I get home today, I'm going to pay $500 plus some sort of co-share or whatever just for doing that. I'm not incented, or I am incented to be healthier and not overutilize that type of thing. So I think that is a huge thing that is in Medicaid that is different. So you take, and you'll hear this from health plans too, you know, they're not necessarily given the controls they need. You know, if we expect them to come in and reduce the ER frequent flyers, but we don't really let them do it, that you're not going to get those types of savings. So some of that is the will to change member behavior, hopefully with incentives. There's all types of discussion now about member engagement and healthy behaviors and increasing their own health literacy. But there's only so much you can do if you're not going to have sort of meaningful controls on member utilization.
So we have, I believe, half of the committee now in the queue. So I'm going to limit you to your original question and one follow-up. So we'll give you your final follow-up here. You can get yourself back in the queue, but at some point we're going to run out of time and just have to cut it off. So,
Yeah, thank you,
So
Mr.
one
Chairman.
question, one follow-up from here
In
on
fact,
out.
I was waiting for that, so, okay. I guess, again, as we look at cost, and you were showing up their numbers of 10% administrative and 2% profit, okay? And obviously, these managed care organizations are for profit. So there you're talking about 12% or so in cost, whereas like the healthcare authority here is, I think we're at more in the 4 to 5% cost range. So why would it behoove us to move in something where maybe our costs are going to double?
So a couple things, this always fascinates me when we compare administrative costs in the public sector versus private sector. And having worked in both, and actually having read the annual report for your state, it's like 4.5% or something like that. I think apples to apples is a really important concept. So we really need to know, what all's being included in there? And based on what I saw in the annual report, it does look like they've done a good job of various administrative costs. But particularly with Medicaid, there's a lot of things that may not get put in the administrative costs. A lot of states don't include their MMIS cost or the technology cost. I think you all do. But what I would do is I would say, okay, well, of these things that are in that 12% of MCO administration, itemize them and try to compare them apples to apples. And I think you'll find that either there are things that are not being put in there for the comparison, that the comparison's not ready yet, or that maybe you'd actually be getting additional things. Maybe when you got to the comparison, you would say, okay, well, we're really more like 9.5% over here versus 12%. And if we were to spend that extra 2.5%, we'll get that extra stuff over there, that extra scope, and we'd really like that. And the other answer I have to that is it's a percentage that you're talking about. So maybe that's good, but it's based on a total number. If that total number goes lower, then that percentage is going to go up on the administrative side. I used to have the same types of comparisons on Medicare. Medicare, when I worked at Medicare, we'd hear claims of, oh, but we've got a 8.5% administrative cost, but Blue Cross Blue Shield has a 13%. So I really think those comparisons have to get more line to line.
Okay.
Representative Lawson.
Thank you, Mr. Chairman. Thank you for being here. I'm right here.
Oh, thank you.
Thank you for your time and sharing your expertise. My question wasn't in the PowerPoint that you presented, but to Senator Hayes' point, he brought up a good point about sometimes we call things by a different name, and there are 36 states, 37 if you include DC, that have expanded Medicaid, and there's many of which are ballot initiatives, were adopted by ballot initiatives. And Oklahoma is facing that, which I'm calling it Obamacare instead of Medicaid expansion. I'm just curious, the ballot initiative that could be before the people of the state of Oklahoma would be to adopt that constitutionally. How many of the 37 have done that, adopted it into their constitution?
I don't know how many. I think this came up in Florida a couple of weeks ago as well, because it was trying to get, I guess, ensconced in the Constitution. I don't know. I will try to look that up and get it back to somebody if I can get a contact. I don't know. I've written a good bit about the ballot initiatives themselves. To me, it's very fascinating. And as I think in the pro-expansion community, everybody got really excited when things got on the ballot, and I'm like, but wait a minute, you still got to pay for it, still got to pass a budget bill. But to your point, I don't know. I will try to find out more, and I'll also see what I can learn. I know Florida's had a decent write-up, because that led to some other interesting conversations about, wait a minute, we put this in the Constitution, that's a whole different thing, and there was a memo circulated that had to do with actually Medicaid's optional. There was a kind of a big kerfuffle about that, but I will leave you my card when I leave, and we'll get in touch on that.
Senator Stanislavski.
Thank you, Mr. Chair. Thank you for being here, and incredibly helpful. I can now say I've learned 190% more acronyms than I have ever known were an acronym.
Thank you.
So, and I grew up in many fields of acronyms, but thank you. This is excellent in terms of cost, but one thing that I didn't quite catch within the presentation is improvement of outcomes. Can you address that? How do outcomes improve by using MCOs?
I think, and I probably should have had more examples besides Ohio. Tennessee is another really good example because they've had managed care for so long and have been measuring it not only at the HEDIS metric level, but at other ways too, including episode-based care. So the basic idea is we set a very specific target. So improve, I don't know, let's say say you're in the bottom 25 of some particular measure, but you also have a lot of interest in improving, maybe opioid treatment, right? That's a big one with a lot of states right now. Well, to your MCOs next year, let's say you had MCOs. Next year, you want to see at least a 25% year-over-year improvement of some measure related to that. Those measures, the beauty of using the HEDIS measures, they have to be, they can't just report them any way they want. They have to be submitted to the National Commission for Quality Alliance, NCQA. They get audited. Only certain people can do the calculation. So it's a very knowable, you either did or didn't meet the target that we put in your contract. And then you see year over year, and I bring up Tennessee because you can see year over year, they've plodded along over the last 15, 20 years or whatever. So you do it at the measure level and you tie it to their payment. And every state has those examples. And I mean, not all plans improve. Sometimes they go down, and that weighs in on your decision to renew their contract.
Follow up. To follow up to exactly that, I'm not sure I heard anything about health improvement. I mean, you talk about HEDIS and you talk about you want something in the plan, but how has the actual outcome of the patient been improved? And that's what shouldn't have been my follow-up, because that's a clarification of the question.
Okay.
My true follow-up is, are there member satisfaction surveys that also show that the members prefer the MCO version versus pay for service?
Right.
Do we see any of that as well?
Right, and a lot of states use CAHPS, if you're familiar with CAHPS, Consumer Assessment of Health Plans. And you'll see, depending on, most of the data that I have seen, yes, over time, if you're able to track patient to patient, once they've got experience with the managed care, same thing with providers. Yes, there's opposition to begin with, but over time, it's a preferred thing. But it is important. And some states, I think, tie payment also to CAHPS, the consumer assessment stuff. And if the outcomes themselves, it depends on the measure. So and it's a good point, because if you don't watch it, it's just a process measure, right? Like how many vital signs did we make sure we take or whatever. So look at things that we have a better, prenatal care is a good example. We know the timeliness of prenatal care absolutely impacts low birth weight. So it's still a proxy because we're still largely measuring things that some people might call process outcomes, but some are more important than others. Or an outcome measure would be the HbA1c below 7% or whatever. There's a lot on the diabetes piece of that, which actually could be considered an outcome measure. Yeah. Good question. Thank you.
Representative Rowe.
Thank you, Mr. Chair. Thank you also for being here today and sharing your expertise. I'm going to pick on Clay, the diabetic, for a minute, and mentioning the A1C just a minute ago. When we're looking at the MCOs, and I think that those do have a very important part in managing especially chronic illnesses. And in some areas of the state, we have different socioeconomic factors that compound those issues. But I'm going to talk about Clay, the diabetic, who really likes to drink Dr. Pepper. And Clay's A1Cs are always 9 and above. And when Clay comes in for his visit, he preferences his blood sugars like, I just can't give up the Dr. Pepper. I drink 5 or 6 a day. That's important when you're looking at specifically models that if you've got a outcome-based reimbursement to your provider, how do these plans incentivize the consumer, other than positive health outcomes? How do you incentivize the consumer to be more compliant with their, exercise, their dietary modifications? I don't see that addressed anywhere.
Excellent point. And to some extent, what I was trying to get at with another question I answered about the member behavior. And I think my first piece of my answer is it's not being addressed in fee-for-service for sure, right? We're not changing those behaviors there without managed care. My other point is we've made a lot of progress in being able to give member incentives, whether that is if I do certain things as the diabetic member, if I keep my A1C down, or if I do certain health assessments, or if I do a class, or I participate in a nutrition program, then I can get gift cards or various other types of things. So the MCOs, and I recommend making that easy for your MCOs to do that. Not every state does that. But you can set aside funding to provide different incentives for changes in member behavior. And the last piece that I would say of that is there's a whole other industry that has come along that we loosely refer to as care management that is doing that's their whole purpose, is how do we engage Clay the diabetic in improving his own health. And it has to do with educating Clay and incentivizing Clay. And there are many companies that sell those services to the health plans to better do that as well.
Representative Marty.
Thank you, Mr. Chairman. And thank you very much for joining us today and going through that. I think it's important for everyone here today to remember that healthcare is a business. I appreciate that Representative McIntyre and Senator Hayes spoke to the increase in costs. That was obviously the biggest thing on my mind as we went through this, and that the MCOs, whether it be for health or PBMs, are responsible for negotiating those prices. So whether it be a pharmacy or a doctor, they don't have the ability to name a price. So that being said, you're very lucky that we dealt with PBMs last year, or else I would have hounded on that. I think everybody in this room's heard me go over that far too much. But I wanted to help me understand potential savings for the state when we're going to duplicate the services, because most states offer some of this, in addition to hiring their MCO. And then speak to, if we know, are there any studies from states that have moved to managed care that show the jobs lost in the state, the money going out of state versus in state for those services? Is there any economic impact that shows what the states are actually saving versus dollars cost that we're sending out of state?
There are studies of that. It's usually related to, okay, WellCare just built a giant new building and it added 300 jobs that time. Usually what I see is related to the addition of jobs with something like a call center or the case management piece of it. And again, it's going to be tied to specific ones. Evelyn in Kentucky is another great example. It was actually a law. It's detrimental in the case of Kentucky because Evelyn was planning on, Passport was planning on adding more jobs, which is tied to Medicaid revenues.
Follow up?
I guess a follow-up to that point would be, as far as research that I've done and looked at from a cost perspective, obviously we'd want to look for a difference in outcomes. And January 2018, the Government of Accountability Office found that there was only one clear-cut case, which is the state of Oregon, that documented an effective managed care implementation under the 1115 waiver program. Can you speak to their findings on that?
I'm not familiar with that particular report. I'm familiar with probably the Carolyn Yoakum, who probably did the report. I could get more information on it, but I'm not familiar with that one.
Senator Hicks.
Thank you, Mr. Chair. And for point of clarification, I would assume that the previous conversation discussing diabetes was aimed at type 2 diabetes and behavior determinants versus
Yes.
a type 1 diabetic.
Yes.
My question, obviously, as my colleagues have talked about, the rising cost of healthcare. My son has type 1 diabetes, and as I've looked to obviously try and enhance, quality measures for him over his lifetime, the one thing that remains consistent in our, cost structure, if you will, with our healthcare system is an exponential growth in administrative overhead. Is this adding an additional layer of complexity with a managed care approach with administrative cost as a result of adding administrative complexity both at the federal and state level for our healthcare consumers to be informed consumers?
My first thought is it's shifting cost. So you're now spending, and I don't mean in your personal situation, but in the overall model, you're now spending on a better management of conditions what you used to be spending on worse outcomes. So whatever it costs you to not have managed type 1 diabetes, again, not for your son, but for a subset of Medicaid members, you're now removing that cost because it does cost something to do medication reconciliation and care management, a broader continuity of care. I think the question has to be asked, not are we adding costs, but what are we now getting for what we're buying, and is it better than what we were getting before? I think is a real question.
Follow up.
Thank you, and I appreciate that explanation. I guess my remaining question is this actually attacking, the root cause of the problem for the consumer, which is that it is an incredibly complex system to navigate as obviously an informed family and an informed consumer. This, in my opinion, seems to be adding an additional, like PBMs, and another layer in the profit margins. So, I mean, is the cost worth the outcome? I think is the question that remains for me personally.
I think the answer is it's really up to you as the state. So if you think we're going to bring managed care on, we're going to write a check, that you're not really going to get, you're just going to be adding costs, right? But if you instead invest and stand up divisions in the agency to make sure it's managed correctly, just like you would any other vendor or whatever, then I think you'll get those benefits. And I know Medicaid health plans are different and that's a point I probably should have made earlier. They are, not all of them, I'm generally speaking, but most of the people that work in Medicaid health plans got involved in this because they had a kid or themselves or a family member that they were advocating for. So when you see a director of policy at WellCare, that person is an advocate for the Medicaid member. It's not the same as if we're talking about our commercial insurance or whatever. So, I mean, they really care about help. You're talking about how hard it is to navigate. I can't navigate my own insurance. I mean, it's ridiculously hard. So that's a big part of what helps drive, continuity of care and better outcomes is helping the members navigate that. And this is what we're all struggling with. How do we do this better and better and better and better? And that's member engagement and care management.
Representative Fugate.
Thank you, Mr. Chairman, and I'm going to be upfront, admit that my head is swimming after all that we've gone through this morning. So I have two questions, both of which dovetail off of things we've talked about already. The first one deals with something Senator Hast was asking about. And so if the managed care organization profit model is based off of the percentage of spend, there really is no incentive to keep costs down. In fact, there's actually a perverse reverse price pressure that happens. So if we go down that path, what insights can you give us in how we might structure things to do things differently?
Good question. And there are, to deal with that, especially for states that have had managed care for a while, constantly evolving in how they, there's risk sharing arrangements as well. So if they can reduce costs, then there can be a gain share. The managed care plan may be able to share in those benefits. The states that I know, I'm trying to think of a good example of states that are that I would really want to hold up as go talk to them. You may, let me think. Maybe one will come to me while we're talking, but you don't have to just do the rate, right? To where as you're pointing out, well, why would you ever reduce cost? You can also do something that says, okay, and by the way, if you improve this outcome or reduce overall cost in this way, you can share, and it's an opportunity for them to benefit more financially or lose. You can, you don't have to just have carrots.
Follow up.
Thank you, Mr. Chairman. And the other question then deals with something that both Representative Marty and Senator Hast mentioned, and that is we've learned from previous meetings of this task force that Oklahoma already has a pilot project that deals with primary care physicians that are doing managed care. Can you talk about, just kind of in general, some pros and cons? And you've already touched on it a couple of times, but pros and cons between that and the managed care organization model?
Sure. And correct me if I get it wrong, but I think you have basically a primary care case management program in which you probably pay each of the, this is not unlike what my state, Alabama's been doing for a while, and other states, but from that other chart, you can see states are leaving that model. Maine has done it for a while. And usually what you're doing is you're paying that physician $9, $10, $15, whatever it is, per member per month for a certain panel. Usually I see they'll allow $1,000 to $1,500. So it's just another chunk of money that can, for more process type stuff. Make sure we filled out this, make sure we did that. I don't want to disparage the good work that's happening there, but it's only happening really in the primary care physician's office. It's not compared to managed care, which is orchestrating the entire healthcare delivery system, you know, with related case management, that types of things that go beyond what Dr. Ferris would make sure he filled out to be compliant, you know, for that type of funding each month. Again, I don't know much about your program. Maybe it really is impacting measures that you've been able to see, and if so, that's great. But I think the big thing is it's just a very sort of tunnel vision. It's only what happens in the physician's office versus what can be coordinated across a broader healthcare system.
My name's next on the list. I recognize myself. I'm happy that this slide has stayed on the screen the whole time, because it really, and in all honesty, maybe this question is better for the Foundation for Government Accountability than you, but I'm going to ask you because you're the one standing up here. This slide paints a completely, I will say, irresponsible trajectory for our nation financially. Why would I do this short of just suspending my belief in everything I know about finances? Why would I sign my state up for a program that is clearly going to drive us into bankruptcy?
Do you mean Medicaid itself or managed care?
Medicaid itself.
Well, that decision was made before your time, decades ago, whenever your state adopted it. And I would argue that if this chart, if we could go back in time, if we had a time machine, we could take this chart to 1965, it might have been a different turnout. That is, you know, we're on this path. And the only question is, can we attenuate that angle a little bit? I cannot give you a good answer why you would do that. I know you were asking it in a certain way, but.
Well, no, I believe it to be an unanswerable question. So you have another slide that shows kind of the trajectory of risk, you know, getting risk away from the government. Managed care is actually in the middle of that. Accountable care organizations was at the end. There we go. So when I saw this slide, I thought that you would say, as the presentation went on, that the reason that you want to kind of stop in the middle with this managed care and not go all the way to ACO is because ACO requires the state government to manage the care. But then one of the very last things you told us is that we're going to fail at managed care if we don't invest in governance. So I guess my question is, if we're going to have to make a major investment in governance, why would we not go all the way to the Accountable Care Organization? And I guess may need you to define ACO as part of the answer to that question.
And I'll start there because I think that you're right. That is the most important thing to do first. So so remember, ACO's largely a concept until kind of codified in ACA in PPOC itself. And when I think of ACOs, they're basically health plans, but run by doctors more than anything, along certain risk models that, you know, there's a whole lot of, you know, what conditions are we treating? How do we not get dinged for having sicker patients? Who gets attribution? And the reason I didn't, and I don't recommend, that's just not where you start. You know, I think you really, it is, in a way, it's a form of managed care, but I think it's very complex. It's very hard to get the attribution right in terms of, is Dr. Clay responsible for these 5 train wrecks, even though the person saw, 10 other doctors. It gets very challenging, it gets very political very quickly. I think you could start, with a pilot program, with a particular health system. If you've got a group of providers that are maybe, with a high-performing hospital system that are saying, hey, we want to take on these patients for this particular condition. They're usually very narrow, too. A lot of times they're for only a handful. Everybody wants to start out with knees and hips, certain surgeries or whatever. I just think that's not where you start, and I think it's not a total solution either. It might be something you add on in addition to other options. Is that helpful? Okay.
Representative McIntyre.
Thank you, Mr. Chairman. Okay, so there's this philosophy out there that business always does it better. Business does it better, always better than government can do it, because there's a profit motive behind it, and that creates efficiency and all this stuff. You know the argument. And as legislators, if we had 3 arms, we would be pulled in 3 different directions by patients, providers, and payers, right? So that profit motive also brings a concern for providers, because the provider would say, hey, when the MCO stops, because there's no doubt in my mind, for the first 2 or 3 years, an MCO would bring some things really into line. There's no doubt about it in my mind. But then the providers where I live say, well, what happens when they get the ship turned around and they're not making the type of profit they were making? They can only go 2 places. They can go to the hospital or providers to their reimbursement rate or their rate, right? And they cut those rates to get more profit. Or they can be a lot more strict with their care protocols and denying care, which is a nightmare for a legislator getting calls about a company denying care to one of their constituents. And this is only intensified in rural areas. And what have you seen? You don't have to address that other stuff. That was all fluff, I guess. But in rural areas, what have you seen, especially, I know capitation can take all kinds of iterations, but what have you seen in other states in regard to that rural piece? Are they simply carved out? Do they stay on a fee-for-service model? Have the MCOs done a good job in those rural areas, is what I'm asking.
Right. I think, so this comes down to FQHCs in almost every state, the federally qualified health centers. And, to some extent, there's a whole other history of their 110% cost reimbursement or whatever that is, so there's challenges in fitting that into any new model. What I have seen more often than not is a lot of times they'll be one of the only providers in that area. So without having been in any price negotiations or anything like that, you as a state, you can require them to have a certain type of relationship with those types of providers. So they have a bargaining position from that perspective. I have a consultant that works on my team that specializes in FQHCs, and we have wondered, what it's like, and the question is different depending on if you're an expansion or not expansion state for those rural providers. But the good news is, if I can touch on some of the fluff as well, sure. In both this question, you're talking about network basically in rural areas, which every MCO wants to work in your city, right? But you need to make them do right in the not city. You get some of that enhanced governance with the federal requirements around grievances and appeals. So that gets to the denials. If you're familiar with the Medicare process, you can't just be big bad MCO. You have to justify why you do things. So you get a bigger stick, and you get much. I'm always hesitant to disparage how fee-for-service performs, but we really don't know how well it's performing right now because you don't have to report these things in the same way that you can force a managed care organization to report these things. So you get more governance possibilities on both of those things, on both the network side and on the member authorization service side.
Thank you. Appreciate it.
Representative Newton.
Thank you, Mr. Chairman. Thank you, Mr. Ferris. Appreciate your presentation. I'm Representative McIntyre stole my question, but I'm going to try to come back to that. I'm also a rural representative, and so my access to care was one of my main concerns. And so from what I'm understanding, you say these FQHCs are probably as best provider because most of your managed care groups have closed provider groups. And so I may end up with providers an hour away close. And so is that, you're saying the FQHC is the closest thing we can do?
So by default, for a certain for sort of first line care, by default, there's a lot of FQHCs, but they have become, maybe you can go and get a baby delivered there if that's the closest one, but they've become kind of the clinic of the areas, and they become, by default, the behavioral health provider for these areas. And it depends. I mean, there are some that, it's hard to get providers to be there, but you can get a different service array. But for the most part, it's going to be a smaller service array because of the providers that want to live in those areas. And that, I think there are opportunities to, and I think we ought to push MCOs to cover some of that gap, whatever that is, whether that's telehealth, we could talk about telehealth, whether that is standing up some type of runs around the state nurses, piece of what you require them to do to get out to those rural areas for certain things, whether that's requiring your MCOs to do health fairs once a quarter. I think you can add more coverage in there that's not in there now in a lot of areas.
Follow up.
Thank you, Mr. Chair. So now on the provider groups for these MCOs and all that managed care organizations, are we seeing doctors dropping out? Are we seeing doctors joining in? Or what is the trend there on that?
So some of this gets into another kind of pet issue of mine of what is the true provider participation rate, even in fee-for-service Medicaid. What I have seen is I don't see many providers turn down a Medicaid contract. I mean, the volume is just, especially facility-based providers, it would make no sense to say, all right, I'm not going to do 60% of my volume anymore, depending on where you are. And to me, it's not, I think there's a lot of opposition up front, but I always question the true price structure, and this is the skeptic in me, because we don't really know. We're just told what charges are and that type of thing. So it's not bad enough to make them turn away from Medicaid in droves compared to wherever it is now, is what I'm generalizing, but that's what I typically see. And then you do have other options if you look at, if anybody here is familiar with the special needs plans in Medicare, something like 17% of those are run by the providers themselves. So the providers can, one day talk about the big bad MCO, and then the next day they're the big bad MCO themselves because it makes sense, right? And there's better clinical things that happen with that too.
All right, the queue is closed. We have me and Senator Hast and then lunch. And my question, I just have one, but I will address the elephant in the room and see what your take is pretty much across the board, every hospital and doctor in the state of Oklahoma thinks that this conversation of managed care is directly from the devil.
Right. Right.
So are their fears of managed care justified or are they irrational?
Respectfully, I want to answer it in that way.
Okay.
But I would turn it back with, what are the commercial managed care organizations that you find better or worse to deal with? Who are your other payers that you're happy with? Because let's force an honest conversation. Managed care is not terrible for providers. Otherwise, they wouldn't take payments from Blue Cross Blue Shield for everybody whoever does your state employees or whatever else, these other employers. So I think it's usually pretty knee-jerk, that initial opposition, but what I have seen more and more, and I think this is very important, is include them in the process in a big way. You know, if you're able to say, we're going down this path, we're not fighting whether or not we're going down this path, and we want you to have a major role in it, whether that's a provider-led entity or we create different boards that include, you know, you pair up with a medical, all these MCOs have medical directors, you know, there's the colleague-to-colleague thing. Okay, I take that back. I will answer it as answered. I think it is irrational, but it is logical because it's change. It's a big change. And it's kind of like a conventional wisdom, you know, that I think is unmerited.
Senator Haste.
Thank you, Mr. Chairman. Now I just have one question. This is actually a follow-up to your answer to Chairman McCourtney earlier when he was bringing up the large number that we're looking at in the trillions of dollars and headed towards bankruptcy and that type of stuff. And your comment was, well, you chose to do this. Okay, we're at a point now where it's about making choices for the future. So bringing that graph into perspective and the ramifications of if we were going down a path, not so much about managed care, but expanding Medicaid. That means our cost, and we're tied in right now at a 90-10 split,
Right.
which, and some people have said, well, that's a great deal. But isn't reality that the 90-10 split is probably short-term, looking at how those costs are escalating, the number of dollars that we're talking about, that we start out at that level, but our costs are going to go beyond a 90-10 split, 85-15, 80-20, or maybe eventually at the 60-40 that it is today
Right.
for traditional Medicaid.
Right. First, I am the odd man out in a lot of my circles, in which the way I answer that question is, whatever you're being told you will spend on expansion, multiply it by 2, 3, 4, whether that's the per member level or how many will enroll. And that doesn't even get at if you maintain that FMAP, that 90%, right? I do personally believe it is, based on everything I've seen, it is not, if you want to go back and be able to make decisions that you're happy with from a fiscal perspective, 50 years later, whatever, it would not be one you'd be happy with if you chose to do that. It's just such a, we can see in other states. We can see in New Mexico. We can see Arkansas is trying to back out of what they, there's various examples. And I didn't come prepared to talk about expansion today. I can do that some other time. There's a lot of work I have on it. But to answer your question, that's why that chart took that increase, right? Somebody was mentioning, I think you were talking about, you were going to say Obamacare, not Medicaid expansion. One thing we really learned about ACA, the PPACA or Obamacare, it was by and large a giant Medicaid expansion more than anything else. So that's all I'll say. I know folks have lots of different opinions, and trust me, I navigate this all the time in my healthcare world. But it would not be a decision that is in any way improving that cost for your state.
Thank you very much, Mr. Ferris, for being here, for your time. We went longer than we had told you we were going to go, but I just felt like we had a lot of good questions going on. So I will start by, or end by thanking the presenter that will be here right after lunch. She has already agreed to move that presentation back a little bit so that everyone will have time to eat their lunch, so they'll be in a good mood when they get here. Our next and final presenter of the day is Elizabeth Goodman. Liz, I guess, would be, we're supposed to call her Liz. She is Executive Vice President for AHIP, and I will stop my introduction there and just hand it over. She would prefer, I keep making noise with the microphone here. feel free to interrupt, which is kind of makes it awkward with the working through the chair thing. So if I'm not looking, just kind of jump up and down, throw things at Representative McIntyre, whatever you need to do. But she said that it'd probably be easier if we ask questions as we go along. It's a whole lot of information packed in here. So ready or not, here we go. Thank you very much for being here. And yes, if you could give yourself a better introduction than I just gave you, that'd be swell. But thank you.
I am Dr. Elizabeth Can Goodman. I work for America's Health Insurance Plans. We are the National Health Plan Trade Association. Our headquarters is in Washington, D.C., but we have staff that cover all 50 states and the District of Columbia. Our mission is to create and accelerate positive change and innovation across the healthcare system for consumers and purchasers. And so with that, these are our values. I'm not going to read to you the slide. I will tell you a little bit about our background, or my background. I probably can't give you the history of AHIP. I received my JD and my master's in social work at the University of Maryland in the early 90s. I went shortly after I graduated to Florida and became the staff director of the State Commission on Long-Term Care. At the end result of that was a package of legislation that included what is now the state's Managed Long-Term Services and Supports Program. From there, I worked as a full-time consultant to a large provider system in Central Florida, then went to a large law firm where I both did healthcare transactional work and also worked as lobbyist in Tallahassee. I then went to WellCare Health Plans. I was there all in 6.5 years in 2 stints. In the middle, I went to Genentech, which is a large biopharmaceutical company. And most recently, before coming to AHIP 11 months ago, I was for 2.5 years on the senior staff at the Medicaid program in the state Commonwealth of Massachusetts. I was Chief of Long-Term Services and Supports, and on the executive team during the implementation of the state's new managed care plan, which I will explain to you, but it is a hybrid ACO-MCO model. About 7 years ago, the CEO of WellCare showed up in my office one morning and he said, we are throwing everything we can think of at improving our quality scores, and they're not moving as far or as fast as we would like them to, and we're can't figure out why. So I took all of our data, all of our quality data, all of the underlying chart reviews, all the claims data, and I gave it to a really expensive consultant, and they churned through it for about 6 months, and they came back with nothing. So I went back to my boss and I said, I can hire another really expensive consultant, or I can take biostatistics because I haven't taken it since social work school, and it's been 20 years. And I left his office and I went back to my office, and he followed me back to my office and said, are you kidding or are you serious? That became sort of a boulder rolling downhill, and I ended up with a doctorate in public health from the University of North Carolina at Chapel Hill, not in biostatistics, thank God, but in health policy and management. So that's a little bit about me. I am a true Medicaid nerd. While I can probably answer most of your health insurance questions, I love Medicaid. It's my thing. So I had planned to go through all of the things you see up here. Some of that is repetitive from the previous speaker, so I don't want to waste your time with that. Real quickly, what I'd like to do is take you through what's in the packets I put in front of you, to answer some of the questions that I'm not sure got completely answered earlier, and then to focus on some key slides, if that's all right. So in the packet that you have in front of you, on the left hand, in addition to the presentation, on the left-hand side, you have, AHIP is a member of something called the Modern Medicaid Alliance. Through Morning Consult, polling was done in each state about Medicaid. In Oklahoma, you'll see these are Oklahoma-specific results. 62% of Oklahomans had a favorable view of the Medicaid program, and 87% said that it was important to have a strong and sustainable Medicaid program in the United States. What they want from their program, you can see in that wheel at the bottom, right? that it needs to be affordable, it needs to be cost-effective, and it needs to be accessible. It needs to be effective, and it needs to be high quality and efficient. And what we can say to you is that Medicaid managed care has proven itself to be efficient, to meet all of those goals. But that's just a resource for you. The Modern Medicaid Alliance website, we're happy to provide, but if you type Modern Medicaid Alliance into Google, it'll pop up. The next one is a look at health insurance. This is not Medicaid, but health insurance generally in Oklahoma. I'm sorry. You know what? That's not in the slides. This is just in here. So that's just for your information. The third thing is referenced in the slides. This is an overview of accountable care organization use by state Medicaid programs. It's just the reference document. There's an example of some of the work that one of our member plans, which is called Care First, it's in Maryland. Believe it or not, Maryland has rural areas. They're way out west. It's called Garrett County. How they're working to cover gaps in care in rural Maryland. And then there's a series of white papers that AHIP produced on various aspects of Medicaid managed care. Also in here is a Center for Healthcare Strategies overview of the use of value-based payment in Medicaid, and one from Manat as well. And then you will see in some of my slides, they look a little bit like eye charts. So these are the actual tables, large enough to be visible, just because this is not a effort to make you squint. It's an effort to provide the information you asked for. And then the last piece is a piece from the Commonwealth Fund about Medicaid provider networks and the network adequacy standards in Medicaid. So that's what's in the packets. That's for your review. You also have my card, questions, comments, anything, anytime, day or night, we take them. We hope our purpose is to be a resource to you. So please ask, and we will do our best to answer the questions. So I want to go back to the question that was asked earlier of the presenter about coverage in rural areas and his discussion about the importance of federally qualified health centers. I would say it's probably also true in terms of that unique role that community mental health centers play. So there are certain types of providers. What many states have done that move to Medicaid managed care is that they will identify a group of providers that they consider essential and require the plans to contract with them. Usually they will set a rate for those providers because otherwise the provider kind of has the plan over a barrel and can ask for whatever number they want if they're essential. But that is generally how that has been handled. With respect to getting plan coverage, which I understand was a historical issue here in terms of having multiple plans, in Georgia, Missouri, and Florida, I am aware, I'm sure there are other states, what they have done is that the carrot for the plans is the urban area. You can't have the urban area if you won't serve the rural area. And so that tends to solve that problem. In this presentation, I refer to capitated managed care, meaning full risk managed care, as comprehensive managed care. That's how CMS refers to it. So the previous presenter referred to it as risk-based managed care. I just don't want things to be confusing. So that's just a whatever, rule for the road. This comes straight from the CMS website. This is current Medicaid enrollment numbers. The CMS website is not the easiest thing to use in America, so these numbers are 2019. All of the other numbers from CMS are 2017. That's what's out there. So this just shows you which states have expanded, which states haven't, how many enrollees there are. So if the state wants to enter into Medicaid managed care, they have several options in terms of authority, meaning the mother may eyes from the federal government to implement the plan. You can do it under state plan authority. That limits the amount of flexibility you have in the program. You can do it under Medicaid waiver authority, and these are each of the examples, or you can do it under Medicaid, those are 1915 A's and B's, or you can do it under an 1115, which is broader waiver authority. Most of the recent Medicaid managed care implementations have been under an 1115, and they are married with a delivery system reform implementation project, which is referred to as DSRIP. And DSRIP is how states handle the maintenance of their uncompensated care funding. There are 4 federally recognized types of managed care under the Medicaid program. Managed care organizations, so that was what Mr. Ferris used, that term, and that's probably why. That's how I'll refer to them as MCOs going forward. Primary care case management systems, that's Sooner Care. That's referred to as PCCM. Prepaid inpatient health benefit plans, or PIPs. PIPs are things like behavioral health hospitalization plans, and PAPs, which are ambulatory health plans. Those are often behavioral health, community-based care, dental care, transportation care, things like that. So my continuum's different from his. Mine goes from less risk to more risk. So a completely provider bears no risk program would be fee-for-service. They agree to participate, they meet the conditions of participation, they sign a contract, they deliver service, they bill you, you pay them. That's a fee-for-service program. That's what old indemnity insurance used to look like in the commercial market. A primary care case management program, that's Sooner Care. That is a fee-for-service program where primary care providers are paid a management fee to manage the care of the member across the continuum. The third is accountable care organizations. I'll go into a little bit more detail about how they work, but that is a system of providers who have agreed to work in an organized entity that take on some percentage of both what we refer to as up and downside risk, but they win if they achieve the objectives and they lose if they fail to achieve the objectives. But it is not full-scale risk. And then risk-based managed care, which is generally done through managed care organizations, and that is full risk capitation. This chart you have in your packet.
Let me interrupt here.
Sure.
Before we get too far past. So I want PCCM.
Yes, sir.
Primary care case management.
Yep.
So this is, just to make sure I understand, so you're paying a primary care physician to do case management, is that?
Well, you're paying the primary care physician. It's not usually the physician himself doing or herself doing the management. It's their nurse, the case manager they hire, maybe a community health worker, but yes, you're paying their practice.
Okay, so are those, I guess, how do you hold their feet to the fire for actually improving quality in that system?
Hard in a straight PCCM system. Many states have implemented patient-centered medical homes, which are sort of the next level up from just a primary care case management fee. And 2 states have what I would characterize as sort of a patient-centered medical home plus, which is like an almost ACO. It has a lot of the attributes of an ACO, but not quite the whole continuum. And a lot of states have implemented either patient-centered medical homes or what are referred to under the Medicaid law. It's sort of a distinction without a difference, but it's a different name, a health home. And the distinction is that in certain instances, when you create this for certain disease states, there is an available enhanced match. Those are often administered inside of Medicaid managed care. So you can have both.
Okay, so we have patient-centered medical homes or whatever that is. I've always thought calling them homes was confusing because I because my brain's not very big, I guess. So that's closer to ACO than PCCM. That's somewhere in between those
Yep.
two.
If you were looking at, at the continuum, a patient-centered medical home that bore risk. Now, some bear risk and some do not.
Okay.
If it bears no risk, if it's just you are measuring its quality and you're holding it more accountable than just paying, say, $5 per member per month and saying that's your care management fee, right? If it has some risk attached to it, it's closer to an accountable care organization. If it has no risk attached to it, it's closer to a PCCM model.
Representative McIntyre.
Thank you, Mr. Chairman. So just for clarity for everybody
Of
here,
course.
you left PCC Plus off of the continuing, but it really is pretty much a hybrid, but it can be. I know it can take a lot of iterations, PCP Plus, but it's between the two. It can.
PCMH plus.
Okay, yes, sorry.
Yes,
Yeah.
yeah.
Okay, yeah.
Because there's a whole,
Yeah, yeah.
we are awash in acronyms.
Yes, we are.
Yes.
Thanks.
Yep.
All right, sorry, I just, before we got
No, no,
too
no.
far past, because we've talked some about this primary home model thing, and so again, I guess to clarify, there are MCOs that use that model inside their system for some of the outcomes. Is that a fair statement?
Most of them do. So when with the health plan that I worked for, we not only had contracting, value-based contracting with patient-centered medical homes, but we had a whole team that supported those, the practice transformation, that would actually work with the practice, that were employed by WellCare to help the practice obtain patient-centered medical home certification.
Okay.
You had a question?
Representative Marty.
Thank you, Mr. Chairman. When we talk about value-based medicine, would you just maybe elaborate a little bit? There are a couple different models going on in my area in the state. Some working a little bit off of bundle payment, and then there's some others. But explain to me, are we just talking about the insurance company limiting someone with a knee replacement or hip replacement that's elderly for 21 days and then they're out? Are we talking about controlling cost, or are we talking about actually doing some kind of chronic care management where we're managing the patient versus just managing the patient's hospital stay / assisted living or skilled nursing, their SNF stay? You know, are we just talking about looking at data points and saying the average person that has a hip replacement or CHF, this is how many days they should be in skilled nursing versus letting physicians make those decisions? Or are we actually talking about working with the patient where we call someone from the insurance company, case manager, actually calls the patient, goes over their new medication, their new diagnosis, gets them to diabetes management courses? Like, I just want to make sure that I understand what we're talking about when we say you're managing their health care value-based versus fee-for-service, that we're not just, or maybe we are just talking about these are the limitations that we're going to give, and the hospital and the SNF are going to work inside of those for a certain amount of money. And of course, then hospital readmits would all play into a part of that. But we end up, I believe, with a lot of the bundle payment system, we have so many days in the hospital, then they're getting kicked out, where maybe they're not ready to be out of the hospital and into skilled, and then out of skilled, back home. So just, can you go over that, whether it's just a process or if we're actually reaching out to the patient to affect patient health?
Yep. So thank you for that question. So we would not consider it to be value-based payment unless it had a quality component, unless it was tied to a quality outcome, right? Otherwise, you're restricting care. The only way that a managed care organization is successful is if they make people either better able to manage a chronic condition or well if it's a solvable condition, right? So a value-based contract has to meet three components. It has to be cost-effective, it has to be patient-centered, and it has to improve the quality of care that the patient, that's delivered to the patient. Now, there's lots and lots of models for delivering that. I don't really have an opinion on bundles, right? But any mechanism that is value-based has to, in fact, deliver value to the consumer. So this is slide 23 in your packet. And you also have the source document, which came from Manat. It says Manat across the top of the document. As of 2018, they counted 18 states that set value-based payment targets for plans, meaning X% of your payments, patients, contracted providers had to be in a value-based contract defined across that continuum that I just described. And CMS has laid out a continuum for what they refer to as alternative payment methodologies. That means in the alternative to fee-for-service, that go from, I'm just going to pay you a bonus if your quality scores are better than the baseline, to you're fully at risk and you're achieving all of the benchmarks that are set, and there's grades in between. The 12 states require plans to set out a VBP platform, a strategy. I'm going to achieve X and Y and Z over the period of the contract. 10 states have set out standardized models for value-based purchasing. To the senator's point about the state being able to define, we want this to be about quality, and so an ACO, a PCMH, a health home, or a bundle looks like this to us, and you have to implement it this way. 10 states require MCOs to participate in a standardized value-based purchasing model. 5 states set it as a percentage of patients whose care is in a value-based model. 1 state does it on basis of premium revenue, meaning X% of your premium revenue has to go to value-based purchasing. And then, I'm sorry, I clearly left out the number of states. So we have half a parens, but I'll fix that and send it back to you. There, at least 1 state has an escalating percentage over time, meaning, X% of contracts are value-based, on the day 1 of the contract, ascending over time to a higher number. Many, many, many states impose financial penalties or provide financial rewards based on the amount and type of VBP. They want this to move fast. They want the plans to be implementing these value-based methodologies. And 2 states set a target for the percentage of plan contracts that include value-based. So as opposed to your revenue or the number of patients, it's actually the number of contracted providers. Does that help? Does that answer the question? Okay. Okay. Keep going? Okay. Sorry. Okay, so you have this document in your packets, wall-sized, you can actually sort of see it. So this comes straight off the CMS website. It just tells you the number of states by population type, and Mr. Ferris walked you through those population types, that use these different models, and whether those models are mandatory or voluntary. As of June 2019, more than 72.2 million people were enrolled in Medicaid and CHIP, 65.6 in Medicaid and 6.6 in CHIP. CHIP is the health insurance for not quite as poor, but still relatively needy children. As of 2017, which again is the most recent data that's out on CMS's website, 55 million Medicaid beneficiaries were receiving care through comprehensive MCOs, and 41 states utilize Medicaid managed care to deliver care on a mandatory basis for some or all of their populations. So a lot of this was covered by the previous speaker, so I'll just run through it really quickly. Our estimates are around $7 billion saved by 2016. MCOs are subject to very strict oversight and accountability standards. Those include network adequacy standards, standards for provider access, standards for quality, standards for reporting, standards for fraud, waste, and abuse oversight. I was telling somebody earlier, when I worked for WellCare, we submitted monthly to the Commonwealth of Kentucky 93 reports, because that's how accountability is done in the Commonwealth of Kentucky. MCOs also facilitate access to non-medical services. So often, you know, a question was asked earlier about the challenge of navigating the system, even if you're me, right? And I do this all day long. I'm the person someone calls when they need to choose, like somebody in my personal life, when they need to choose a Medicare plan or an ACA plan, right? And I decided this is what I'm going to do when I retire. But it is impossible to figure this out. And I actually was with a very high-ranking administrative official who had a health incident, and he was talking about how hard it is to navigate the healthcare system. And that's really the beauty of Medicaid managed care, is that you walk in the door and you are assigned a care manager. And if you end up in the hospital and you don't risk stratify to a point where it's identified at the front that you need a care manager, meaning you're otherwise well, you're not interacting with the health care system that much, but you find yourself in the hospital, you're going to get outreach from a care management person to help you with that transition home, right, or that transition to the rehab hospital. And all of those things about what the expectations are for coordination of care, for continuity of care when you move from the commercial insurance system to the Medicaid system or between Medicaid health plans, all of that is in your power as the state regulator to set out by contract. There are states, for example, who have managed long-term services and supports programs or managed care for the age, blind, and disabled, who literally set out in contract the care manager to patient ratio. So that is really in your hands. Unlike any model that is based on fee-for-service, where you are not paying on a capitated basis, it provides more budget predictability. You are setting out rates on a yearly basis. You're submitting those rates to CMS for approval that they are consistent with CMS's actuarial soundness standards, and the plan is taking the risk that the patients assigned to them or who choose them might cost more than that. They have very established outreach and member education programs that might include community health workers, it might include 24-hour nurse lines, it might include school-based health services programs. It just depends on the plan. They have very sophisticated analytical capacity. So, these are companies that are sitting on large bodies of data from which they can identify population health trends and then use those to design interventions to where they are seeing activity. And then finally, on the risk management front, MCOs are licensed insurers, and so therefore they have to retain financial reserves, and they are regulated as an insurer. I talked about access to a continuum of care. Medicaid health plans almost always cover everything from primary care through post-acute care. In many cases, they also cover acute, long-term services and supports and home and community-based care. They have very sophisticated administrative functions in terms of claims payment. We always would say at WellCare, we may not pay the best, but we certainly pay the fastest. The coordination of care, that's the job, right? It doesn't work. We can't save you money if we are not coordinating the care across the continuum. And then this is where the contract is so important, and Mr. Ferris spoke to this. You need to align what your expectations are with delivery, with what your expectations are for outcomes, and then hold the plans accountable to that. That's their job to deliver. This is an overview of ACOs in Medicaid. Again, This source document is in your folder. It's a white paper from CHCS. Of these states, 12 states have active Medicaid ACO programs. 10 more are thinking about it. Of the 12, 5 of them contract with MCOs and require those MCOs to contract with the ACOs. 2 of them have both ACOs contracted with plans and ACOs contracted directly to the state. And in some cases, those ACOs have to meet all of the attributes that the Medicaid, that the health plan does as well, so that you don't create unintended risk. And then the rest have what I would characterize as sort of a hybrid model. And I'm happy to talk to you about what a hybrid model looks like if you have questions. So ACOs are designed to improve care coordination and delivery by holding providers financially accountable for the health of the patient populations they serve. This accountability is achieved through 3 things: implementing a value-based payment structure, so all the metrics of value I just talked about, measuring quality improvement, so there's a set of standardized measures and they're measured against a benchmark. Usually that benchmark is themselves, and then, or a state average, and then collecting and analyzing data to essentially do what I just described the plans do. Now, often there is a very large infrastructure cost for the state because the provider organizations are not set up to do that complex data analytics work. And then there are 2 payment methodologies generally. One is a global budget, meaning I've looked at all the patients who have come to your hospital historically, and based on that, I'm projecting your global budget will be this, and then you're measured against the global budget after whatever the measurement period is. And then the other one is a shared savings arrangement, which is whatever whatever is achieved in terms of shared savings. If you hit your quality benchmark, then you can share in the savings with the managing entity, whether that's Medicare or Medicaid. There are ACOs in both. There's also ACOs in commercial. The quality metrics are tied to payment, and providers typically will not receive a portion of the, they won't get paid if they don't hit the quality threshold. States implementing ACOs have to establish and maintain their own data infrastructure, right? So the data has to come to the ACOs from someplace for them to manage the population. And as I said, states have typically borne a fairly significant expense helping the providers to come up to this level of sophistication necessary to do this data management. I'll stop there before I move on to general Medicaid quality requirements.
Thank you. That's a great place to stop. I'll start asking questions if others don't. So I mean, to me, it sounds like an ACO is a state-run MCO. How is that wrong?
Well, they're not run by the state. They're run by the provider organizations. The state continues to bear the risk that of any financial, it is not a predictable budget because it is still a fee-for-service model. What you have is a coordination of usually not all the care, only either the primary care, you can have a primary care ACO, or you could have an ACO that's responsible for the primary and inpatient acute care, but it is generally not, it is based on total cost of care for the patient over time, but it's not sitting on a managed network of specialists, other hospitals, home health agencies, any of that. The network is unrestricted. So where you have a Medicaid managed care plan, or a commercial managed care plan for that matter, the managed care plan is responsible for claims payment, network development, provider relations, enrollment, you name it, they're responsible for all the functions. On the ACO side, they're responsible for managing the care and only the care.
Senator David.
Thank you, Mr. Chairman. So on the ACO side, are there ACOs that are embedded within an MCO system, a managed care system? Can you have ACOs that contract with the MCO for a certain segment of care?
Yes, and I think I said 5 states that have active ACO programs have them inside of Medicaid managed care. So let me go back. So let's see. Washington has managed care and ACOs. Oregon has what I would refer to as a hybrid model. So they're called coordinated care organizations. They're regional. They often include health care providers. Well, they all include health care providers, and then some include health plans. Some of those health plans are AHIP members. Utah has a managed care model with ACOs contracted to it. New Mexico. Minnesota has one standalone ACO, I believe. They may have more than one, but they also have them contracted through plans. Iowa through plans, Missouri through plans, Louisiana through plans, Virginia through plans, Maryland, Delaware, Pennsylvania, New York, New Jersey. I think that's Vermont. Is not a plan state. Rhode Island is a plan state. Connecticut has that PCMH plus model that I was telling you about. Maine is currently a fee-for-service model with ACOs. Colorado has a hybrid-ish model. And no, I can't do that backward.
No, that's fine. Thank you. So just expanding on that. So can you kind of explain to us in this type of a model where you have MCOs and you have ACOs and maybe you have other like behavioral health homes? I mean, so who's responsible for the case management? And is there just still that one case manager that navigates that whole system for the patient in that type of system?
This is your typical Medicaid answer, it depends. In some of the models where the ACO is contracted to the MCO, the ACO is managing all of the care across the continuum because they're at risk for total cost of care. In some of the models, they are managing the care, the medical care, and where non-medical services like long-term services and supports are also included, you have a sort of wrap care management that goes around it. Where you have health homes, CMS requires one care manager, right? And so that's sort of part of how you get the enhanced match for being a health home. And so you have to have that care manager as the lead person. It might be somewhat clarifying, although it might make it more complicated, so I apologize if it does, for me to talk a little bit about Massachusetts' model, because I was there for its implementation. So Massachusetts has 18 plans. That's a lot, just saying, by anybody's standard. There's 3 or 4 per region. There are 3 types of plans. There are 3 ACOs. None are, well, I think one is statewide, the rest are just in their specific region or regions. There are 2 statewide health plans. They cover all regions. And then the balance, so 13, are marriages between an ACO and an MCO. We refer to these affectionately as models A, B, and C, because otherwise it was really confusing. And in that case, which is the one I'm the most familiar with, the acute care management and the service delivery, the medical service delivery was all with the ACO. And then the rest of the network that was outside of the provider organizations that are in that ACO was built by the MCO, and all of those administrative functions were done by the MCO, all the ones I just named. And so that's kind of how that worked. Added to that complexity were 2 sets of community-based providers. One is long-term services and supports community partner, and the other is behavioral health community partner. And those essentially act as health homes. and the care managers in those senses sort of come in and out as the person has the need. It's a highly complex model.
Follow up. Oh,
One more, and I know the answer to this, but I feel it's really important for everyone in this group to know the answer to this. I mean, it's obvious that if, and I think our previous speaker said it quite well, that if you've met one MCO plan or managed care plan, whatever the plan is, you've seen one managed care plan. So every state, it really depends on what your state needs and what your state is trying to integrate, what type of care and the path they want to go down. So that being said, it's a very technical process. Are there experienced professional consultants that will come in and help a state evaluate their system, evaluate where the state wants to go, and help that state be able to navigate the contracts and what they want to end up with that contract for a managed care system?
Yeah, actually, I got asked that question earlier, and I would say to you that Administrator Verma, that was her job before she became the CMS administrator. So yes, there are
She's leading the witness.
lots of. It wasn't she who asked me the question, but anyway, yes, there are consultants who do this. Like anything else, different consultants have different depths of knowledge, both about the local market and about the complexity that is Medicaid. Medicaid it's like falling down a well. I don't know how else to describe it.
Thank you for the leading questions. Representative Stark.
Thank you, Mr. Chair. Is there a place or is there a way of knowing which of these marriages or not marriages gives actual measurable, predictable, some kind of outcomes that are health outcomes, not financial?
So and I was just about to get into how quality is measured in the Medicaid program, but each of the states submits to CMS quality data through something called TMSIS, which is a federally required data system. The first report card came out last year. It is probably not useful to look at 1 year's data, both based on completeness of the data and because you could see that the quality in state A is better than the quality in state B, but there may be underlying provider network things that cause that have nothing to do with, it's very unfair to compare Massachusetts to Mississippi. Doesn't matter what the model is, right? But over time, you will begin to see whether, based on those publicly available data, there are differences in quality scoring in, say, Colorado or Oregon, which are hybrid models, versus Georgia or Florida, which are straight Medicaid managed care models. What you have today is the HEDIS data. The previous speaker spoke to HEDIS, which is the Healthcare Effectiveness Data and Information Set. That is a limited set of measures promulgated by the National Committee on Quality Assurance, which is also a accreditor of health systems and health plans. And it's really process and outcome measures. It's not measures of patient satisfaction, but those data are available today. But again, I would caution you to look at the state year over year versus looking at state A versus state B, because it's kind of, they're not comparable.
Follow up.
Thank you. And is there a place to see that, like in
Yeah,
graph
HEDIS
form
has
of
a
each
website.
state for the last 20 years or whatever?
I don't know how far it goes back, but this is the HEDIS website. This is what it looks like. And the purpose of putting it in your presentation, you have this also, is to show you these are the Medicaid health plans in Ohio, and these are their commercial health plans. And you'll see that the consumer satisfaction, prevention, and treatment scores are not that different, and that in fact in Ohio there are some commercial plans that are red, but no Medicaid plans. But there are less Medicaid plans, right? But that's what it looks like. If you go on this website, you have the link right there. This just happens to be Ohio. You can look at the HEDIS scores. How far back they go, I apologize. I have no idea.
All right. I'm going to cut in front of Senator Hicks because I want to follow up on your question. Because looking at the faces out here, I think everyone is possibly getting more confused. Let me try this because I think I'm trying to go the same place she is. So does the decision on whether or not we do an ACO or an MCO, what drives that decision making? I mean, is one a better financial system and the other is a better health outcome system? I mean, what would drive us one way or the other? I don't know if there's any way to answer that question. I'm just trying to understand why some people do one and why some people do the other when in the end they look very much the same in a lot of ways.
Well, they're not, they can be the same from a care management standpoint in terms of what you hold them accountable to do. So in Massachusetts, the contracts for Model A, Model B, and Model C have the same responsibilities in terms of what we expect them, what we expected, I no longer work there, the health plans and ACOs to deliver to the member from a care standpoint, right? From an administrative standpoint, network standpoint, claims standpoint, known cost savings standpoint, accreditation standpoint, all of that, Medicaid health plans can deliver that and ACOs can't. ACOs don't manage network. So if you have bad providers in your, federal law requires Medicaid, traditional Medicaid fee-for-service or PCMH to take any willing provider, regardless of quality. That's not restricted in an ACO model. The ACOs don't pay claims. The ACOs contract the way that on the terms that are appropriate for them in terms of having providers participate in those ACOs. They're very selective about it, but they don't meet credentialing, national credentialing standards the way that health plans do. They don't have the same fraud, waste, and abuse infrastructure. So when I was in Massachusetts, I had the whole post-acute portfolio and the integrated products for Medicare and Medicaid eligibles, and we hired a third-party administrator that was basically a risk-free MCO to do utilization management, prior authorization, and fraud, waste, and abuse work for us because there was wild overutilization of those services. So none of those functions exist in an ACO. They are similar in the care delivery side. They are not at all similar in the administrative side.
So in a straight ACO state, and this is maybe what I was trying to ask earlier, what I'm going to call back office side, so you've got an ACO that's managing a network and managing quality outcomes and kind of driving the health outcome train, and then you would have the state or some contracted entity or multiple contracted entities doing what I would call the back office part, which is paying claims, waste, fraud, abuse, a lot of those things. That's
correct. But you would have, as they would, I mean this affectionately, one throat to choke if you contracted with a plan, right? If you have one group doing the third-party recoveries and one group doing your auditing and one group doing your claims payment and one group doing your network management and so on and so on and so on. One, the infrastructure and overhead cost of that, the admin cost, is extraordinary. And two, you will get from vendors, it's that guy, right? Whereas when you have a managed care plan, right, it's one-stop shopping, right? You're calling plan leader X and saying, Bob, we got a problem.
Okay. All right. Sorry, thank you, Senator Hicks, for, I guess, allowing me to cut the line.
Thank you, Mr. Chair. I'm probably just as now thoroughly confused as I ever was. So this might be way off base.
I'm sure not.
So I'll just stick to my line of questioning, and you can make your judgments later about my depth of knowledge. I guess my question is specifically on page 15, the slide that you were showing about the overview of ACOs and Medicaid. Obviously, this gives us, somewhat of a limited snapshot about, this particular subject. But to draw attention to a state like Utah, where their delivery system and their delivery model was somewhat overhauled, and I don't know if it was in conjunction with or if it predated what you're showing here, with this physician or provider-led delivery model where they started to embed mental health professionals within those primary care facilities as well. Is that part of the managed care piece? Can it be designated as part of an ACO? I mean, I guess I'm trying to understand if we are, moving to a situation where we recognize that we have room for improvement and we're looking at, obviously, large sum of data to try and compile. Are those pieces, or can they be combined somewhat if you're looking at delivery models and systems with the managed care piece?
They can all be combined. So let me try to take that in order. I'm sorry I can't speak to Utah. I don't know anything about Utah. I will go research it because I know a lot about many of these other states. On the co-location is really common and the outcomes are really good. Many providers are already doing it. Many plans are already doing it. But it is something you can absolutely incent or require by contract. A lot of times where the challenge lies in co-location is the number of available behavioral health providers. We nationwide have a wild shortage of behavioral health providers. And so while co-location is always the goal, it's very challenging. It's often ameliorated by using telehealth for behavioral health delivery, but doing it in the PCP office. But the answer is, yeah, using managed care, you can build into any of the contracts whatever you want the plans to do. And so Mr. Ferris kept referring to North Carolina. North Carolina has not yet implemented. They actually just delayed their implementation. But they have all kinds of cool stuff that they have worked into that contract. They have a quite famous maternal and child health model that is driven by their public health system, on which federal legislation is currently pending to kind of write that large. And that is integrated into the contracts because, of course, you don't want to leave on the sideline something you've already built that's great. And South Carolina is doing something similar. So yes, the answer to your question is yes, and that was not at all a stupid question.
Follow up.
Thank you, Mr. Chair. So my Senate district is right here in the heart of Oklahoma City. I have one of the largest medical systems, I guess, in the state with Integris Hospital Systems. And our new head honcho is relocated from Utah, who was at the table to design and help implement that particular delivery model. And so, I guess Integris currently has the second highest level of uncompensated care in the country. And, I think that kind of flips some of the narrative on its head as this being a rural versus urban situation, in that with some of the disparities that are leading in those rural areas drives a different consumer potentially to some of our more thriving health systems. So I guess, in essence, as we look to the experts that can help us, kind of craft or create some of these intricacies of models that we've seen, just be incredible for specific subsets of people, I guess, would it be most important to potentially identify what those core objectives or what those core targets have to be in year 1 versus year 2 versus year 3, and how do we get to that level of depth?
So, yes, I mean, you absolutely have to know where you're going in order to develop a value-based contract, right? Because you want your end results to match whatever your community's goals are for care. The other thing that Mr. Ferris mentioned that I think is critically important is you have to have everybody at the table. So before I got to Massachusetts and then continuing while I was there, they had what were called implementation councils. Those were publicly procured. They met over the course of a year and a half. Those implementation councils basically came up with recommendations in the various areas of their expertise. So some were about acute care, some were about primary and preventive care, some were about behavioral health, some were about long-term services and sports. I can get you the whole list. It's out on the Mass Health website, www.mass.gov. That was how they were able to set those goals. Sure.
Senator Haste.
Thank you, Mr. Chairman, and thank you for your presentation. Looking at slide 12, you speak to $7 billion in savings with the MCOs.
Yep.
Looking at that, now first of all, $7 billion is a lot of money. But I'm wondering where the savings came from. Were these states starting with systems that weren't that efficient to begin with, and the MCOs came in and just found a lot of efficiencies and so on and so forth from that standpoint? Because when we're spending $650 billion a year within Medicaid, that works out to about 1%. So I'm just curious if there's any data related to the $7 billion. They started out here, they were really bad, then they got better. So I'm just, because when I'm looking at it from an operating overhead where from the state of Oklahoma with Healthcare Authority, we're at 4.5% right now. So I just want to see how that kind of compares.
Sure, and I'm sorry, I don't know the answer to how that estimate was derived. I am more than happy to go back and pull the data for you and look at where, over what time period and where each of the states measured came from. I'm happy to do that, but it's an outlier. Usually it's more about people with really severe conditions who are not being well managed, who are cycling in and out of the system, and that's where the savings come from. And so it's less that a state had, completely unmanaged fee-for-service and then over 10 years moved into managed care, and it saved, it was unfettered and rife with fraud and abuse, and then the reins were tightened, and more over time about winnowing down the number of people who were frequently flying through the ER and whose, diabetes became under control and, those kinds of things.
Representative McIntyre.
Thank you, Mr. Chairman. Dr. Goodman, I'm
trying to figure out where you are.
I'm here.
Oh, thank you.
I'm going to put the same question to you that I put to Mr. Ferris. And I'm sure you heard that I referenced the Mathematica study and our, about 20 years ago, our foray into managed care. So in your estimation, what's changed in Oklahoma to enable it to work this time when it didn't work last time?
It's a really good question, and I'm not sure that I can answer what's changed in Oklahoma, this being my second day in Oklahoma ever.
Come on.
Beautiful state. Plan to come back.
I'll let you off the hook then. You can research it and come back to me.
I would be happy to do that. I can tell you what's changed in managed care, right? So 10 years ago, managed care companies, particularly Medicaid managed care companies, did not have the level of sophistication they have today. So because the industry has grown, because it has gotten more sophisticated, because the data analytics tools have gotten better, because the science around when to intervene and how to do evidence-based care has gotten better, the plans are better at managing care. In terms of building, where you have large urban areas with large numbers of underserved members, and then you have suburban areas that are, well-served, and then you have very large swaths of rural area. 10 years ago, that was new territory to health plans. Today, they're doing it in Iowa, they're doing it in Kansas, they're doing it in Utah, they're doing it in Eastern Oregon. This is not new ground for you to tread. The other thing is, again, I know nothing about Oklahoma, so I apologize, but as I understand it, you had a very limited number of participating plans. And therefore, the state was somewhat at risk of the plans choosing to no longer participate. And I think that has changed. There's a very robust and competitive market. You will unquestionably have multiple bidders. And then the last thing is, back in the day, rates were generally set at a straight per member per month, didn't matter how sick the person was. Today, virtually every state uses risk-adjusted rates. You get paid more for taking on sicker folks. You get paid less for taking on more well folks. And so the incentives are now in the right place, and those risk adjustment methodologies are quite sophisticated.
Follow up.
Thank you, Mr. Chairman. Okay, so you may have said it. My phone's been doing all kinds of stuff, and I've been reading
Happens
other
to
stuff.
all of us.
Yeah. So we know the cost driver in the Medicaid population, the traditional Medicaid population, is the ABD population, right? So is that where MCOs really concentrate their effort? I mean, to me, that seems that would be the place where they could make the most impact and get the biggest bang for their buck quickly. Is that fair for me to say that that's where an MCO generally would focus? And if so, what techniques do they use to drive down the cost of the cost-driving population? Does that make sense?
It does, absolutely. So I would say ACO, or MCOs, I apologize, have the most experience with moms and kids, right? They've been in moms and kids the longest. And they're very, very adept at that. They often use, Text for Baby and all kinds of incentives. Like when I was at WellCare, if you did all of your prenatal visits, we gave you a car seat or a stroller. They do all kinds of things to engage moms and kids in their care. Is the amount of utilization, is there more room from a cost-saving standpoint? No, right? Those are generally less costly members. And the capitation rate is lower as well, right?
Easy. Yeah.
With the age blind and disabled, those are folks who often need a lot of help, and therefore they spend more. And with them, it's, to go back to the previous answer, it's risk stratifying those members, identifying those folks who are moving through the ED very quickly or have unmanaged conditions, or maybe homeless. Now data systems allow you to identify, for example, federal definition of homelessness is 3 moves in a year, to find those people because they're much more highly at risk of having all kinds of bad outcomes because of their homelessness. Health plans have identified different ways to engage with people that will, help them. And then again, all of this integration, the work towards integration of behavioral health, that is a lot of where you see a lot of management around the ABD, right? A lot of people are determined to be disabled on the basis of their mental health.
I have no idea where we are in your presentation at
Quality.
this point.
We're on quality.
I hope you do. Go ahead.
Okay, so these are the federal requirements. Sorry. I am not good at this. Okay, since 2013, federal law has required each state to submit a core set of child health measures. when I was explaining before that there's these scorecards out on the CMS site, that they include those child core measures. In 2012, they promulgated adult core measures. Those are optional for the states. Most states do keep them, but they're not mandatory. The ACA required the child core set to be submitted. They are also required, and Oklahoma is required today to do all of these things, to have a quality strategy, but states that have managed care have to have a quality strategy that meets these standards, right? So they have to have the state has to have a procedure to assess the quality and appropriateness of care and the services delivered to Medicaid beneficiaries. So the question that I got before about, is this just restricting services? There are actually, the state is required to assure that this isn't all about restricting services. That they have to have procedures that identify the race, ethnicity, and primary language spoken of each Medicaid enrollee. The reason for the primary language is that there are federal regulations around what the top number of languages are that materials have to be printed in, and in order to do that, you need to know what languages folks speak. Procedures that regularly monitor and evaluate compliance with the quality measurement requirements, arrangements for annual external reviews, so EQRO organizations, external quality review organizations that come in and review the managed care plans. Intermediate sanctions if a health plan is not complying with the quality requirements, information systems that support the ongoing operation of, you want your plans to be reporting on their quality, the state has to have a system to take all that information in and review it, and then standards for access to care, structure, and operation, and quality measurement and quality improvement. So these are just some examples. We talked about what HEDIS is before, and all the citations are on your slides. In Massachusetts, they saw that Medicaid health plans exceeded national benchmarks 83% of the time, compared to 43% in the state's PCCM program. In Minnesota, a study found that Medicaid health plans outperformed HEDIS metrics, meaning outperformed the national average on 19 of the metrics. In Georgia, a study found that children in Medicaid health plans were twice as likely to experience child visits, 6 or more well-child visits during the first 15 months of life. And children ages 12 to 19 were more likely to visit primary care providers. In Ohio, of the 15 child core measures, 14 improved each year from 2016 to 2018, and the remaining one improved in 2016 and 2017, remaining level in 2018, none declined. And then in 2016, 59% of children in Medicaid health plans received 6 or more well-child visits in the first 15 months of life, whereas 23.5% of children in the fee-for-service system met the metric, and 69.7% of the children in Medicaid health plans received well-child visits at age 3, 4, 5, and 6, while 39.9% of the children in fee-for-service met this metric. Finally, in New York, if you think Massachusetts is complicated, you should learn about New York's Medicaid system. Among the state's non-specialty, that's what they call mainstream Medicaid plans, of the 76 quality measures, the state has its own quality measurement system called QAR. It includes network adequacy, consumer satisfaction, complaints about the health plan, HEDIS, CAHPS, the whole shoot match. Calculated each year from 2015 to 2017, 39 improved in each year, 28 remained stable, and only 12 declined. Of the measures of adult health, 20 went up, 4 remained level, and 6 went down over the 3-year period. And of adolescent health, 19 measures, 12 went up, 5 went down, only 2 went down over the 3-year period. We've seen these slides, so I'm going to skip them. We talked about value-based payment. Okay, last slide. You guys have really important safety net providers here. They're critical to your system. Can't do business without them. You've got to protect the supplemental payments you have. assuming the federal government continues to allow supplemental payments. Different topic for a different day. Those can be preserved in Medicaid managed care. Prior to the recent, what we like to refer to as the mega rule and the mini mega rule, the two Medicaid managed care rules that were promulgated over the last few years, those payments could be directed payments through the managed care plan. They cannot anymore, so there's two ways to do it. One is to negotiate a DSRIP waiver. California, Texas, New Jersey, Massachusetts, there's more. They all have DSRIP waivers. And then the other way to do this, or in addition often done, is to put it in the MCO's rates and dictate rate setting. So I know that question often comes up, so I wanted to make sure I covered it. In the back of your this is how you find us. You have my card in your packet, but you also can get any of the AHIP branded materials in your packet there. And then here, just because I didn't know if these questions would come up or not, this is the current expansion map. This is expansion group enrollment, again, a little dated. So since the map, Maine, Virginia, Nebraska, Idaho, and Utah. This is Medicaid managed care enrollment by model by state. And there's 3 slides. And then this is more detail on the differences between the models across the continuum. And this is more detail on each of the states that have the ACO models. So that is it.
Representative Newton.
Thank you, Mr. Chairman. I may be a little bit going out on chasing a rabbit here, but on quality measures that they're recording and keeping track of, how many on the adults here, how many quality measures do we have to keep track of if under the managed care portion? Okay. Okay.
Consult the Book of Almanac. Any Monty Python fans in here?
I will find it.
Okay, so I mean, as a state right now, without under the managed care, we have to meet all those or part of those?
It's not a matter of have to meet, you have to report them.
Have to report them?
Yeah.
Correct. But if we under the managed care, we have to meet certain those measures, just
No,
report
you have to
them?
set your quality standard, your strategy, and your goals for quality. And then you have to report back to the federal government how you're doing relative to your goals.
Okay. Regarding, follow up?
Follow up.
Thank you, Mr. Chairman. So let's just take New York, for example. They had 76 measures they were recording. When did the physician have time to see the patient if they're recording 76 different things?
Amen.
I mean, I'm looking at it from the provider's perspective. I don't see where we can have any efficiency in seeing the patients if we're keeping track of that many measures. So I was just curious.
Yes.
Okay, thank
The
you.
answer is yes.
Representative Fugate.
I cannot find it, but I will send you the links to the child and adult core measure.
Thank you, Mr. Chair. I'm going to chase a little bit of a rabbit here, too. I'm excited that today we have someone who was involved in Massachusetts healthcare. We spent 2 of 3 sessions that we've had so far reviewing America's health rankings. Oklahoma, as we have all heard, it ranks 47th in the United States. Massachusetts ranks 2nd. And so I did some digging to see kind of comparison contrast between the 2 states. And what surprised me the most was to find out that Oklahoma spends $87 per person or per capita for health care as provided by government means. Massachusetts does it with just $112, so only $25 more than we do per person. And so I'm wondering if you can give us some insights there, because I see that in Massachusetts only 2% of the people are uninsured, whereas in Oklahoma we have 1 in 6 between the ages of 18 and 65 who are uninsured. What is it we can learn, and how is this possible? Do we just eat more chicken fried steak than they do in Massachusetts, and that's why they're ranked 2nd and we're 47th?
Wow. Even my doctorate in public health does not qualify me to answer why people in Oklahoma rank 47th and people in Massachusetts rank 3rd. I can tell you from my personal experience in Massachusetts that the provider community is very, very sophisticated and has a history of integration. They work well together, which is really important for members. And the state apparatus is organized into a single umbrella agency that includes not only the Medicaid agency, which I worked for, but the elder agency, the mental health agency, the developmental services agency, the human services agency. They all live within the Department of Health and Human Services. It's more than half of state government. And so the mechanisms of operation of the state government the left hand and the right hand are required to work together because they all report to the same human. And she's an extraordinary human, to be clear.
Follow up, Mr. Chair.
Yes, but just, you said you've only been in Oklahoma for a day, so if we introduce you to chicken fried steak this evening, you would probably have a different answer to that question. So
I might, yes.
just
But
saying.
you do need to remember that I lived in Florida for 22 years, so I'm a connoisseur of grits, and I'm pretty good around a chicken fried steak.
Okay. I'm sorry. Follow up, yes.
So we also heard that when you've seen one Medicaid plan, you've seen one Medicaid plan. I'm wondering, as a Medicaid nerd, if there are best-of-breed implementations that we really ought to be taking into account as we try to figure out what we might do in the state of Oklahoma.
That's a really good question, really good question. So I was at WellCare for the implementation of managed long-term services and supports in New Jersey. And one of the things that really made that implementation stand out to me, well, there were several. First was in the design phase, the regulators were really willing to sit down with the contracted plans and have the plans, walk them through. I plan to implement it this way. Here's how I read your contract. This is how I plan to implement it. I literally did Visio charts of, like, the person calls on the phone and these set of things happen, right? And the people in the Medicaid agency sat down with me and said, no, that arrow needs to go this way, right? And so they were really open and collaborative and constructive. And then beginning about 2 weeks before the implementation, there were daily triage calls, and they went for about 3 months after the implementation. Each plan everybody was on the phone those first few weeks before and the first few weeks after, and then they became plan specific, and it was literally like, we got a phone call that Mrs. Jones at 123 Main Street is having a problem with this, like, go fix it. And it was really, really a terrific model. And I would, Valerie Haar is the former Medicaid director there. There has been an administration change since that time. She is now the head of policy at Horizon NJ Health. I would absolutely recommend you speak to Valerie. It was really an extraordinary implementation. As an outside observer, it appeared that Georgia's original implementation went pretty seamlessly for a Medicaid managed care implementation. That was more traditional populations, moms and kids at the outset, but they also implemented foster kids, and there literally wasn't any noise, which was pretty extraordinary. New Hampshire, relatively recently, implemented, similar in the sense that it's a mostly rural state with population downstate and not a lot of population upstate, and a huge, one huge system, Dartmouth-Hitchcock. And so, again, I think they would be interesting to talk to. Sure.
Representative Lawson.
Thank you, Mr. Chairman. I'm looking at the fee-for-service versus managed care quality, specifically the states of Georgia, Ohio, and it looks like New York, when it's talking about children and well-child checks. And it seems that there's a market increase in just compliance, I would say, or visitation in the managed care model versus fee-for-service. And is that just because they're required to report, or is there some sort of qualifying metric that shows that increase in care?
So that's a core measure. So whether you're in fee-for-service or managed care, you have to report, the state has to report it. The answer is that the contracts incent it, and the plans incent the members to make those things happen, right? So you're contracting with a managed care plan. That's one of the measures the managed care plan is held to. That's devolving into the contracts with the providers, where you're incenting your providers to make those things happen. And then often you're incenting the members. I'll give you an example. I think this question was asked earlier about what can you do with the members. In West Virginia, they implemented a program, I don't know what its current status is, but they historically have implemented a program where essentially you, if you were compliant, you were entitled to certain supplemental benefits that you were not otherwise entitled to. And so, you're very limited in terms of carrots in Medicaid. Doesn't matter what model you pick. That's just the way Medicaid works in terms of, you can't give people cash who are on Medicaid. Show up at the doctor, we'll pay you $5, right? You're not allowed to do that. So you have to be really selective. So as I said, we had this program, WellCare had a program where if a mom completed all of her prenatal visits, we were allowed to give the mom a car seat because it was related to the health of the child.
Senator Coleman. Senator Coleman waves. Representative Newton.
Thank you, Mr. Chair. Thank you very much for your presentation. It's been very informative, and I can see that you know a lot about this. Well, I'm coming back to my reporting on certain health outcomes and stuff like that. If we went into the expanded Medicare coverage, then if the federal government decided that we need to improve our statistics on a certain reporting agency, they could decide not to go along with what you're telling Representative Lawson. They could decide to cut our funding or
Not really. So I'm going to take you down a little well, and I apologize.
You're fine.
Do you remember the second slide about the authority? Okay. So when you enter into one of these, you agree with the federal government that they're going to waive certain requirements of federal law, and in exchange, you're going to not cause the government to spend any more money, right? It's got to be budget neutral. And two, that you're going to meet certain requirements, right? And most of these are done via an 1115 waiver. If you obtain an 1115 waiver, the thing you negotiate next is what's called the special terms and conditions. It's the contract with CMS that says, I'm going to do X and Y and Z, and here's how I'm going to do it. And all of those things, the waiver is subject to public comment before it's submitted at the state level, and then while it's with CMS for their review. So it receives public input. In the special terms and conditions, you can negotiate how you're going to measure quality. I have yet to see one where there's a federal withhold of match for failure to meet the quality scores. Now, I'm not saying that's out of the realm of possibility, but I have never seen one.
Follow up?
Thank you, Mr. Chair. So, but let's say 5 years down the road, they decide that if everybody ate a lemon on Friday, we'd all be healthier, okay? So could they add that to the requirements at that point?
The Medicaid match rates are statutory. So I don't know, but I don't think so. Does that make sense? So by law, all of the different match rates that that Mr. Ferris described, and I won't do it again, those are set out in law.
Representative McIntyre.
Thank you, Mr. Chairman. And it would, if everybody ate a lemon on Friday, it would reduce scurvy. So I want to talk about something that's not really MCO, but it kind of falls in line with this, and just you as a public health expert. It seems to me that, you know, at the federal level, they're paralyzed. We saw the graph of the, you know, the ungodly expense that Medicaid is. Do you believe that any healthcare innovation that we're going to see probably won't be coming from Washington, but will be coming from the states?
I believe the states are where innovation happens anyway. It's why my career has been spent primarily in the states. Only a state can develop that program that is right for their community. And so, you know, it's very local.
Thank you.
Representative Fugate.
Thank you, Mr. Chair. It's maybe appropriate. We're on the screen with the various waivers. One waiver we didn't talk about was the 1332 waiver. My understanding is that Oklahoma had to request a couple of years back to do a 1332 waiver for reinsurance. Could you talk a little bit about your experiences there? If you have any insights you might share with us, is that something we ought to go back to?
Well, we have generally been very supportive of 1332 waivers across the country. I mean, I can't speak to them in detail, but we do think it's a key component of stabilizing insurance premiums, particularly in the ACA market. You know, where the first presenter spoke to some of those uncovered lives, right? The best thing you can do to get some of the eligible but uncovered folks into the system is make the premiums more affordable. And so that goes a long way. Whether you should or shouldn't resubmit a 1332, I'm sorry, I don't really have an opinion.
All right, there's no one else in the queue. I will follow up just very quickly on, you talked about the states being the driver of innovation, and that's kind of your career is based off of that. So as someone who's worked in a lot of states, seen a lot of things, what would your opinion be of a state putting Medicaid expansion into their constitution with specific language that ties the hands of the legislature and keeps them from being innovative?
Well, so I come from a state with some, I think the most constitutional amendments of any state in the union. Florida has, they did repeal the pregnant pigs. We feel good about that. We're very proud. I think, this is me speaking, not AHIP. I think you amend the Constitution at your own peril.
Thank you very much. There are no other questions. I thank you very much for all of that. It was very impressive, very informative, and as one of the members may have texted me, you know, my brain has melted at this point, but that's exactly what we wanted today. There's no way to talk about ACO, MCO, any of this stuff without really getting into the weeds. So I appreciate you helping sort that out and your patience with some of our questions. So thank you very much for being here. Thank you for doing that.